Mr. A, 36-year-old male, resident of Chennai, car driver, married. I would like to take my history since birth. As was told by him to his mother, according to patient himself, he was having crying during menstruation post birth since day 4 and having delay of urine during menstruation. He was evaluated in the hospital and was told to have some defect in urinary tract and will need surgical intervention for it. He underwent first surgical intervention within 1 month of the birth. After 1 month of the birth, patient was still complaining of crying during menstruation and was having recurrent episodes of urinary tract infections. He again underwent another surgical intervention within 1 year of the birth. During this period, he was not having any constipation or fecal incontinence. He was having otherwise normal milestone without any developmental delay. He was still having recurrent episodes of urinary tract infection till year 8. And he was having recurrent hospital admission and OPD visits for this single complaint. He was
permanent kidney problem. He remembered to have serum creatinine 2 at the age of 15. Since then, he was under continuous follow-up. He was advised to have renal replacement therapy at the age of 22. Decreased appetite. And he remembered that at the age of 22, his creatinine was 24 when he was first hemodialyzed. His first hemodialysis was done through temporary catheter. After that, his first left forearm AV fistula was made, which was a primary failure. Then he underwent second AVF creation in left forearm, for which he underwent dialysis for 1.5 years. He then underwent liver transplant at the age of 22. Donor being his mother, KBO compatible without any donor being without any comorbidities. Post-operative renal transplant and serum creatinine discharge of 0.86. He was under constant follow-up from that period. After 3 months of renal transplantation, patient was having fever, having lower abdominal pain and burning menstruation. Patient was hospitalized in ICU and managed with IV and was told to have serum creatinine 8 and was hemodialyzed. Though patient does not remember that he has underwent any kidney biopsy, but he remembers that since then patient is being hemodialyzed initially twice weekly then thrice weekly. Patient has multiple axis failure. Initially was dialyzed from left forearm AVF, then right distal AVF and then right forearm AVF. Then again the patient has been treated left forearm AV graft, but that also got secondary failure. Patient right now is being dialyzed through right tunneling of catheter. Then he is also insisted that he has undergone right side catheterization around 3 to 4 times. Right tunneling of catheter. His intermittent weight gain is around 2 to 3 kg without any dialytic complications such as hypotension, fever, which is any history suggestive of CRBSI. As per the history given by himself, patient has having difficulty in micturition since birth and history of recurrent UTI with history of 2 surgical interventions. Then renal transplantation with the multiple axis failure and renal transplantation at the age of 27 with the renal allograft failure. Then on hemodialysis thrice weekly without any metabolic complications. Since patient is having complaints since birth, probably patient is a case of acute congenital abnormalities of kidney and urinary tract. Probably since patient has complaints from day 4 and he has underwent two surgical interventions, probably it would have posterior urethral valve anomalies failed by a provisional diagnosis.
Do we know any details of the surgery which would
No,
help?
sir, he doesn't remember.
What is the history that would strongly suggest PU virus?
So recurrent episodes of UTI and dribbling of urine.
That's not specific.
No, that he was operated just within 1 month.
Within 1 month.
How do we know all those things?
He has underwent posterior fibrillation or posterior wall.
Which history can be told which will suggest strongly PU virus? Which would usually, something would usually be done and the resident or whoever does it would say this is PU virus, it does the next. That's treating. Easy category. The patient will have all sorts of urinary symptoms, dribbling, crying, not able to pass, maybe even a bladder back. But catheter goes in easy. That's PU. And at least what he might know is whether following those surgeries, there was one of those surgeries done for once in ureterostomy. So did he have another ureterostomy?
No, sir, he does not have.
So it was all, the whole surgery was ureterostomy.
Because of chronic intestinal, because of persistent respiratory reflux and then developed chronic intestinal nephritis.
So, but that he developed urinary tract infections,
Yes, sir.
recurrent and probably.
Yes, sir.
So, if you were to sort of imagine, you don't have information for it, but what would be the kidneys like in this patient?
So initially it would have been hydronephrosis with bilateral hydronephrosis with cortical thinning. So kidney size will be enlarged.
What happens ultimately?
So there's
They remain enlarged, they remain.
so eventually there's shrunken.
What happens to these kidneys? No, you haven't told me what happens to these kidneys. See, one is reflux causes what?
So hydronephrosis.
Yeah, that's good. But what happens to these?
So increased pressure in the cortical
UTIs and all.
cortical scarring, chronic pyelonephritis leading to cortical scarring,
Pyelonephritis. So chronic pyelonephritis leading to
cortical scarring.
So if you were to see these kidneys from ultrasound, many times people would have forgotten about this history at all, and what you see is nothing but scarred kidneys.
Okay, sir.
So they develop, this kidney has proteinuria or no proteinuria?
So he doesn't remember, but there was no history of any frothing of urine.
Yeah, but what happens? Ordinarily you would have proteinuria in them, or
Yes,
it
sir.
would be non-proteinuria?
Initially they will not be having proteinuria, but if it's unilateral reflux disease, then may have patient have secondary FSGs and then proteinuria
Secondary effects.
and proteinuria.
They won't have frothing of urine or full-blown nephropathy.
Full-blown nephrotic, but good amount of urine,
And that's because of
secondary FSG.
effects.
You said he got transplanted at the age of 22.
27, sir.
27. Was nothing done, no evaluation of his bladder, no urine cultures or nephrectomy?
Sir, he was told to have recurrent infections, but he doesn't remember that what was urine culture.
No, prior to transplant, normally if somebody has had multiple urinary tract infections and has PU valves, what happens to the bladder? You've lost the native kidneys because of PU valves, even though they were operated. You said there is secondary reflux. What do you expect will happen to a transplanted kidney?
So,
Means here you want to assess the bladder or not?
so yes,
Why you want to assess?
for bladder capacity and
Capacity and what is that called? The ratio of pressure to volume.
compliance, bladder capacity and compliance.
See, he, at age 1 month, he had PVU1, isn't it? So he had a surgery, he had another surgery done twice. Why did he develop continued urinary tract infection?
Because probably
Surgery
first,
was done. Despite surgery, he continued to have chronic kidney disease. It was diagnosed very early. That is, might give you an answer to what the questions were being asked is.
And probably he got reasonably, something else must have been done. He must have been reasonably well evaluated and treated in childhood, because despite having the disease from birth, for 22 years they managed to preserve his kidney function.
But what are the other associated abnormalities which happen in these people?
so vesicular reflux.
Vesicular reflux. What else?
What is a valve bladder?
Could the development of the kidney itself be affected? They may not develop good kidneys as such.
You told you can't now, so like if there's one abnormality can have another abnormality together is
Yeah.
what, sorry sir.
So it may have
Yeah, fairly common actually.
Very common.
Hypoplasia or
Renal
dysplasia.
dysplasia.
Dysplasias of kidneys are very common with posterior ureter. So very, very common. So these are associated together. So despite doing surgeries, you do multiple vesico-ureteric reflux surgeries as well, they continue to develop chronic kidney disease. And that's basically because the kidneys may be hypoplastic or dysplastic.
So do you think you have completed your presentation or something is left? So basically your presentation itself is incomplete. You have just started abruptly and then stopped. And there is a lot of things are incomplete. Like such thing you should always start with antenatal. Antenatal period, how was the antenatal period?
So
What is there any
because-
evidence of oligohydramnias or polyhydramnias? Okay, that's one thing. Second thing is, you have not mentioned about, how was the milestone of growth at all.
Sir, he was having normal miles without any developmental delay.
Still, you have not mentioned in any of
Means in any of these are what we want to know is when exactly it started the case. Means when is bladder control came. All those things in brief you should tell.
Okay, sir.
Nocturnal enuresis.
Means unless you tell them, we will not be knowing. Because from the operation of 1 year till 27
But-
years, almost many gaps were there.
Just
Patient
to the point
doesn't
you have mentioned,
remember.
different UTIs and then.
Patient is of 37 years of age, he doesn't remember exactly when he started having bladder control.
Tell us at least that you asked it.
Negative
Okay.
history. You
Means,
should
Negative.
unless you tell us,
Okay.
how will we know that you know to ask it?
Okay, sir.
You understood?
Okay, sir.
No, patient will never know the course of illness. Because now after the end of the history, like history is art. You come up with a few of the deficient diagnosis and you go back and ask all the negative history which you have thought of. And during presentation, you should tell all the negative history so that you can, convey us these are things I have thought of and these are I have excluded. So, okay, those things are development history, growth and the deformities of lower limbs and in details. You have just said recurrent UTIs, that's all. Recurrent UTIs and all of a sudden you said creatine, was 2 at the age of 15 and 22 at the age of some 22 years. So those 2 points only. So you should always mention what was the urinary after, the surgery, whether he had a normal flow, when did he attain the bladder training, was it normal, or he had nocturnal enuresis, or he had voidic disturbances. All these things you should be able to. Was the growth normal? Was all other mental the physical and mental milestones were normal? All these things you should be able to ask. Okay, so those were all defective in your case history. And family history also. You should be able to, presenting illness, you can tell and then you can go back to a history, like I want to date back history from, the antenatal period. And then you complete, how about family history? Is there any...
She has she has 3 siblings, all sisters, and they have normal milestone and no kidney disease in them.
You have to, you have to tell us that's what.
Okay, sir.
Unless you tell us, we will not be knowing whether you asked
sir.
or...
Again, few things about the presentation to add to what the madam was saying, because if you look at this patient had ESRD, underwent a living donor transplant, and within 3 months the patient has lost the graft also. So I would think it's not okay to assume that this was a pyelonephritis. So regarding the immunological as well as the urology workup, sir also pointed it out. Whenever we present any case of dialysis transplant, there are certain information, basic information about dialysis transplant that are expected to be presented. For example, now you have told about the urine output, interdietary weight gain, but not urine output, the vaccination status, whether this patient before transplant, this patient should have, nobody will do transplant without a urological evaluation in this patient. So whether this patient had some urine output at that point of time, and whether urodynamic study and other sort of things were done, and whether the patient needed CIC or something post-transplant, whether he was advised these things. So these are things when a case is being discussed, especially when it is for an exam purpose. There are a set of things for each condition which is expected that this will be sought from the patient and will be discussed. Dialysis, for example, you have repeated one thing. I noticed that you are repeatedly mentioning right side or left side, but whether it is femoral or jugular is not
right.
clear. So it's assumed that I know that because but nobody puts femoral, but then we can't assume, because there are instances where you put tunnel, because when recurrent access failure is there, there are instances where we do put say tunneled catheter in the femoral vein also. So small things, but I noticed that at no point of time you mentioned right and left, but not exactly the location. And the graft you specifically mentioned distal, was it a radio forearm you mentioned? The graft is really in the forearm, or where is it?
So arm, sir. So
Okay,
left
so
arm.
you mentioned forearm. So
Left arm.
you mentioned forearm. Okay, so there are few things when you present. Other thing is transplant. This patient had a very early graft loss going back on transplant. So immunological reasons are something which we are concerned about. So it was a cross match done, what sort of induction was given.
So
There was
he
no mention of
doesn't
any
remember.
immunosuppression at all. Was what sort of immunosuppression? Was he compliant? Was there any other issue? Pre-transplant evaluation, what was done? Was it just a cross match, or other things were also done? Immunological workup, was there history of any cross match positivity? Okay, so all these things will add. We should not be assuming that the graft failure is from infectious because there is a urological reason. Could be, but then it could be compounded by immunological reasons as well as other reasons also. So there are a few things with regard to the presentation like I wanted to point out.
See, sometimes you may not have this history. It's quite possible that patient doesn't know what induction he got, what immunosuppression. There are patients in India who may not know what they are having. They are prescribed and they are given. But the presentation should that he doesn't know about the induction or the kind of treatment that he's taking. At least it should become apparent that you did try to find this information. At this point of time, from your history and all, everybody is sort of, but there are many missing links, things which you didn't at least present. So make a mention that small little things become important in the presentation, in the sense, aneurysm, nocturnal, and very important in this patient. Bladder evaluation, I think, would be another very important issue in this patient.
For example, the same patient comes to you at the age of 2 years, not now. So what should be your approach?
Yeah.
It could be different.
Are there scars on his abdomen of the previous surgeries besides the transplant?
No, sir.
So what surgery? He probably only underwent cystoscopic surgeries, whatever interventions.
Ureterosigmostomy, sir.
Huh? Sorry?
Sir, diversion surgery, sir.
Diversion would have shown you some scars.
But this patient does not have any scars.
So it was probably all cystoscopic.
Yes, sir.
Whatever. So as madam said, he's undergone one at 1 month, something, probably a valve fulguration. Again somebody's done something at 1 year, and now he's come at 2 years. What to do? Which investigations or things would you do in what order?
Sir, so USG whole abdomen. Then, sir, voiding cystourethrogram.
You also mentioned what you expect in this.
Yeah.
So in USG whole abdomen at the age of 2, they will be, for that age group, normal kidney size. Probably patient may have, sir, hydronephrosis. In vesico cystourethrogram, there will be reflux present.
what sort of a reflux would come in this patient? Reflux can happen during a cystogram or during voiding.
During
Accordingly, it's a high pressure or a low pressure reflux. What would you think?
high pressure reflux.
High pressure. Yeah. So that itself then tells you that probably bladder pressures are high.
High. So
With MCUG, high pressure reflux would suggest that perhaps. And what else would you see on? If he hadn't been operated,
high pressure.
classic finding of PU valves on an MCUG, and non-operated or incompletely treated. Ballooning of the posterior urethra. What else can you see, which often even the radiologists report wrongly? When you look at even a cystogram or a voiding film on the bladder, what do you see? Trabeculated bladder. It's an irregular filling of the dye which suggests trabeculation. Unfortunately, some radiologists write this is cystitis. I'm having horrible arguments with them. You can't see cystitis on an MCOG, it's trabeculation. So, USG, MCOG, what else?
What are the other bladder thing you can find, like apart from trabeculations
No,
can
yes.
be there? What are the other, when
Something else that will develop in a very high pressure bladder. Diverticulum.
Bladder diverticulum.
So if you have a high pressure bladder now, you have a maybe grade 4 or a grade 5 reflux and a trabeculated bladder, what's the next investigation? And this history of UTIs and prior surgery.
Urodynamic study.
So what will you find out in a urodynamic study? Normally, what is the function of a bladder? What is the function of bladder?
To store.
Storage.
So, while it is storing, urine is coming, what happens to the pressure?
It will be increased, sir.
And there is an increase in pressure, but there is a plateauing of the pressure. It doesn't, despite urine coming in, the compliance of the bladder is such that it keeps on dilating. Okay? That's the compliance. So it doesn't increase the pressure, it keeps on increasing in size without increasing the pressure. Because if the pressure becomes high, then it gets very difficult for the urine to come because the pressure in the urine will. So it's usually a compliant bladder. The pressures doesn't go too high. But what happens in an abnormal bladder?
Have you seen a urodynamic tracer? How many pressure lines are there on it? Anybody?
They trust the urology report.
So there are three. There's a catheter in the bladder which is measuring. There's a catheter in the rectum. And the difference between the two. So one is the rectum is telling you what is the difference between the pressure in the bladder and the pressure, the intra-abdominal pressure. And the difference between those two is the detrusor pressure. Because otherwise, if the abdominal patient strains, and in fact the person doing it asks the patient to cough frequently. Now when they cough, both the lines should go up because it's the abdominal pressure that's rising.
Yeah, there is a third line which
Yeah.
kept on the abdomen also. So when
Yeah.
some people measure abdominal pressures as well.
In a patient like this, is it bilateral reflex or can you get unilateral reflex? Suppose you do MCU and you find reflex only on
Bilateral
one side.
reflux.
No, suppose you
might
do,
find it on one side.
you did and you found reflex only on one side. Is that possible?
So it is possible, but
How is it possible?
Usually patient will have bilateral reflux, but
What is pop-up?
One kidney is already
hypoplastic.
damaged, so the pressure tends to go towards the same kidney and to preserve the other.
May not be as planned, but
That's-
one valve
yeah.
gives way, so that the pressure comes down, so that the other valve doesn't go off, so the other kidney remains protected. It's not that the damaged kidney does something. Yes.
So if you go and knock off that kidney by doing an nephrectomy, then suddenly the other one starts getting.
So where you put the nuclear scan in this? When do you do and what type of nuclear scan? This type of patient.
All these you investigate is only to look at whether what is the etiology and what is the lower renal tract abnormality. You have to evaluate the what you call kidney, whether kidney is functioning normal or
Renal
damage is
scan,
there. So what are the
nucleoside renal
investigations?
scan.
Upper renal tract. Is it possible that you have done MCUG and there is absolutely no reflux? But you still feel that diagnosis is still a primary BUR. Is there a possibility?
Like this patient itself, at 22 he had the transplant, and so if they had done an MCU at that point in time, they didn't find any
Any
reflux.
reflux, which happens
And
very
you-
often.
It is very often, which is not uncommon actually. So was the disease because of reflux, or the disease was not non-reflux?
Disease was because of reflux.
Was reflux. So why don't you find that reflux? What happens? Jaldi bataiye, otherwise what's going to happen is you're not going to be able to finish this case. Then all these people will find that other questions which needed to be asked are not asked. So it's good to
I don't
either say
know.
that you know it or you
So I
don't know it,
don't
so
know.
that we can ask someone else.
I don't know.
You don't know. So what happens to reflux? So if there are 100 children, say, who have reflux, what happens to them as they grow?
There is spontaneous resolution as the age progresses.
Yeah.
And so that is when we repeat it at like a pre-transplant workup, at that time the result might not be seen.
So what sir asked then, which investigation will at that stage tell you that yes, there was DMSA?
DMSA scan.
What will it show you?
So DMSA basically to assess for scarring.
Scarring.
So if the scarring is there, it would suggest that the chronic kidney disease has occurred due to the recurrent reflux which was present at a younger age. And it can also proceed with the DTPA scan, which will tell us whether what is the present functional status. So both will help in counseling of the patient as well as documentation.
Right. So this patient, if he had a urodynamic study and was found to have a poorly compliant, high pressure bladder with trabeculation, what treatment would he have been given, and UTIs? What treatment would you have given him at that stage, which he may or may not have received? We don't know. We only know that he had repeated UTIs which were being managed on a OPD basis. So what would he have been given at this stage as part of his treatment? To prevent anybody? Anticholinergics. So most of these patients will get anticholinergics, or these days beta-3 agonists, because mirabegron is now the favorite drug of the urologists. And then many of them will require intermittent self-catheterization. And then many of them would require UTI prophylaxis. Till what age do you give UTI prophylaxis?
At the age of 5 years.
5 years.
If the bladder dysfunction is there, sorry, bowel bladder dysfunction is there, you can't do it. Otherwise, in 5 years.
What kind of, for the DMSA scan you find, where do you find these scars usually in a patient with reflux?
Cortical scars.
Polar
vision.
Why?
Multipolar.
Why at the polar?
The shape of the papilla, it's
Compound
chain,
chain.
and they are more present towards the
How many papilla does each kidney have?
3,
5 to 6.
5 to 6.
Anyone? About 8 to 9.
9. Yeah.
8 to 9 papilla in each.
So why does the compound papilla result in scarring? There is intrarenal reflux from those.
So which other animal has multi-papilla? All other animals have what? Single papilla. Only one papilla. So pigs are the only other. So most of the research has been done on pigs, on reflux nephropathy. So can you tell me the person who did most of the? None of you.
Tell the examination.
Yeah. I think we should move.
Vascular activity.
Examination, anything positive only?
So, a patient is sitting comfortably on bed and is conscious relative to time, place and person. Vitals pulse rate 78 per minute, left radial artery regular, normal volumic, normal character without any radial delay or radiofemoral delay, and all peripheral pulses are palpable. Blood pressure in right arm is 137 by 88 millimeter mercury in
137.
by 136 by 88 millimeter of mercury in supine position, and in sitting position 134 by 82 millimeter mercury. In left arm 136 by 84 millimeter in supine position and 134 by 86 millimeter mercury in sitting position. Right lower limb it is 154 by 86 millimeter of mercury, and left lower limb 152 by 88 millimeter of mercury. Respiratory rate is 18 per minute, regular abdominal thoracic. Temperature is 98.4 Fahrenheit in left rectal area. General examination. Cardiovascular examination, inspection, there is no precaudal
Again,
bulge.
you should mention all height, weight, deformities.
Yeah.
which
Sorry,
are-
sir.
Oh, those are important. That will give you that include that when patient has.
Also, we would like to know his height and weight because his interdialytic weight gain is 3 to 4 kg.
2 to 3 days.
So, what percentage of interdialytic weight of patient's weight is permissible as an interdialytic weight gain?
10 to
10 is too high. 5%. Beyond how much ultrafiltration? What's a good ultrafiltration rate? 10. Yeah. More than 12 is associated with
intradialytic hypertension.
an increased mortality. That is the Jennifer Flight's analysis of the HEMO study. That when you went to 13, the cardiovascular mortality increased.
In this patient, mentioning the, looking for genu, valgum and the deformities,
Yeah.
evidence of rickets, because the disease seems to have started quite young. So it may not be there, but then it is important to mention that it is not there.
Intermacular distance would be mandatory.
No, I think in this height, weight, all those, even otherwise, in a normal person, you should give height, weight and BMI and all others. These become
Yeah, because most of these patients may be malnourished. So
Yeah.
other reason to mention the
What is
BMI.
his
And
frequency
in
of
fact, he's
dialysis?
also required other deformities. Sometimes they mean, particularly when going to second transfer, now a space also to go for it.
200. He said.
initially to
I missed it. Right. Vascular access examination.
So patient, since patient has both primary and secondary AV failure, patient on examination, patient was not having any thrill or
But how many scars are there?
4 to 5 scars.
2 to 5 is not.
4 scars.
Tells
Four
me that
scars.
you haven't examined.
The
It needs to be exact number.
The graft is still in situ.
You have to explain, in the inspection you have to tell me, where are the scars?
Yeah.
Okay, so that I have not examined.
What is the difference in the scars between graft and fistula?
The graft is in situ still or is been
So
taken
he-
out?
So he doesn't remember, sir.
No,
No, he doesn't remember the frequency.
No, but
I have not seen, sir.
Examination finding is what.
The graft was placed, you said, in the left arm.
Yes, sir.
So that means it must have been a straight graft. So there will be 2 scars. One at the elbow and one at the axilla.
Patient देखा करिए बता दीजिए.
And the graft, if it is still, you can feel it.
You will feel a thrombosed graft.
Yeah, you feel like that.
Means you have to, the examination you have to see. No?
Okay, sir.
Yeah, have you seen a graft and a fistula? They are different.
So I have not seen graphs.
You've not
yet.
seen a
Not
graft?
seen a graft. Very often in based in our center.
So in
But
this,
the-
in
Did
this
the patient tell
patient,
you that he underwent graft then?
Yes, sir, patient told.
And in others, many times the surgeons put a saphenous vein graft.
yeah,
It's very cheap.
so
It costs nothing.
your examination, if you haven't seen it, if he has still the graft, you go and see it, because then you will have seen it, otherwise. Patient would
When you
have-
palpate it, you can
Yeah,
clearly
you
feel
can,
that
yeah.
that is
It's
something
a-
artificial. And they have, some of them have corrugations.
Yeah,
on it.
yeah.
So they are corrugated PTSD grafts.
Graft is still there.
It's still there.
Still there. Yeah. So you should go and
You
feel.
should go and see it, everybody.
What about the transplant surgical scar? Is it on the right side or left side?
It's the right side, sir.
Okay. He didn't undergo any nephrectomy or anything before transplant.
He has a TCC in situ.
Yes, sir.
So examination of the exit site, etc.
It's normal, sir.
No.
You have seen,
Sir.
after examination.
Yeah, I didn't examine the graph, but I have seen, sir, the tunnel
The
cup.
tunnel line. Where is the cup?
Sir, below clavicle, just around 2 fingers,
Centimeters.
2 centimeters, 2-3 fingers.
So why did he lose his graft in 3 months' time?
So, due to graft pyelonephritis and recurrent infections, recurrent graft pyelonephritis.
If you don't mind, sir, when somebody who had undergone transplant, apparently uneventful, 3 months everything goes well. Suddenly he comes with severe graft dysfunction. How will you go about evaluating that patient?
Sir, we will have first history. If patient has a history of fever, abdominal pain and burning situation to rule out graft pyelonephritis. Then history of prior blood transfusion to rule out sensitization, so to rule out rejection.
Will a transfusion after the transplant cause rejection?
No, sir. It may.
Why not? Anyone?
Condition is given.
Yeah, the patient is under immunosuppression.
Suppression.
So much less of transfusion after transplant is much less of a sensitizing event than before.
Yes, so at these 3 months, what are the usual causes for graft dysfunction? Let's go that way. What are the usual causes for graft dysfunction, and how
Sir.
will you go about confirming the diagnosis in this situation?
So first infection, then rejection.
What you tell me is that you are in OPD now. The patient entered in with a lab test. Create has become poor or whatever you say. So how you approach it, what you do, you let me. So that will be very clear how you practically approach. Same patient is coming to you, you ask the history, so how do you manage it?
So we will first take a history of any fever, abdominal pain or burning situation, and is related to volume depletion. Then compliance with the medication. Tac level.
Maintaining, and on OPD, which is first we like to assess.
First and foremost should be an ultrasound to rule out obstructive causes.
Okay.
Start with the history, then examination,
And then ultrasound.
Will be ideal. Don't mix up here and there.
Examinations are then look for graft tenderness, we like to classify.
Just that. You don't want to take any BP.
Overall, yes, sir.
So each and everything will point you to something. So you have to tell me and then tell what points to what. So that it's, we know that you are systematically approaching the case. Don't jump here and there, then it will confuse unnecessarily.
We'll start with the blood pressure, sir. Once we are assessing what is the blood pressure at the time when the patient comes, if it is uncontrolled hypertension, that could also lead to graft dysfunction. Or if the patient is having hypotension, say if he's had a history of maybe diarrhea at the time of presentation or maybe poor intake as well, that can also lead to hypertension.
Just to, sorry to interrupt you, but in this situation, suppose the BP is quite high and there is graft dysfunction, what will you attribute the graft dysfunction to? So it's unlikely it is
That is less.
hypertension nephrosclerosis, right? Okay, all right. Go ahead.
These things like poor intake and the thing is usually not very common in a transplant. Their appetites are usually increased, and weight gain in the routine situation, at least weight gain is what we find we have to warn them against. Especially on steroids.
Suppose you find that there is no diarrhea, there is no fever, there is no graft tenderness. You do an ultrasound, kidney looks, there is no evidence of obstruction, and you say culture is also sterile. So what are the other? So infection is out, obstruction. At 3 months, you really don't expect it to be an obstruction, but still obstruction seems to be out. Rejection still may be. What else can this be? Vascular BK virus abrupt presentation unlikely, no? Okay. All right.
How much you think BK virus you are seeing so like that sudden graft dysfunction? Then what put that as the first treatment?
Yeah. What else can present as a sudden, which apparently was going on well, then abrupt graft dysfunction and
TAC toxicity.
TAC
What about
toxicity.
urological causes?
Ureteric obstruction.
At what stage post-transplant are you asking them?
This is 3 months.
3 months.
3 months.
Any other medical cause which is sort of you need to intervene soon, otherwise, and it may be treatable. I'm trying to. There's something which we need to consider. That's what. It may be a disease which was pre-existing, or it may be a new one now.
TM.
Rheumatoid microangiopathy can present like this, right? It can present at any point of time, can be early. So in
Post-transplant, they don't present with that florid anemia and thrombocytopenia, just graft.
Just a graft dysfunction.
and it's important to recognize it early because you may have to institute plasma exchange and other things.
Somebody said ultrasound for obstruction. What do you find on ultrasound?
And do you think because it's a primary kidney disease is bigger, its obstruction will be there?
Sir, I don't know if this is proven physiological in a transplant, but if it is significant.
All transplant kidneys have hydrogen unless you do them with the bladder emptied twice, because no urologist is God or nature to make a perfect anti-reflux mechanism. So unlike the native kidneys, you have to evaluate with the bladder empty, whereas with the native, the sonography is always done with the bladder full.
The 4 DDs should come immediately. Infection, rejection, toxicity and recurrence. That's why there is a delay then,
So what would you do to make a diagnosis? So if you were the
It's a kidney
treating
biopsy.
physician,
It's a graft biopsy.
Straight.
So if the cause of perineal injury or graft
then you
pulmonaris
done the ultrasound and all that.
rule out, then we will go for the donors.
What do you find on the biopsy? What do you expect on the biopsy in this patient? In this patient, biopsy was not done.
No,
Isn't
sir.
it? At least that's what you said, that the biopsy was not done. So if you did the biopsy, what would you find? What do you expect at 3 months in this patient? You would have done the biopsy, isn't it? If you were the
Yes, sir.
treating physician, so you would have done the biopsy. So what would you find?
Now what you are expecting? Not only have to-
Pyelonephritis.
Do you think his picture is of a pyelonephritis? He has no fever. You
It's a fever, abdominal,
abrupt.
He said fever.
fever, abdominal pain and
Fever
burning
and
sensation.
abdominal
Abdominal
pain, he
pain.
said.
Okay.
No, that can be actually, signs of rejection also. Rejection can have
Fever,
systemic
graft
phenomena.
tenderness, can
So
be
it
there.
Can be.
Pain abdomen. Yeah.
And don't get fixed with the idea of, because your stress is only on either it's a pre-transplant post or UTI. You are fixed with UTI. Recurrent UTI, pre-transplant.
After 8 years, till 22 years till he got transplant, there wasn't any urinary tract infection, isn't it? That's what you said. He
Yes,
had continued recurrent UTI till 8 years old.
Yes, sir.
Isn't it? After that, he didn't have UTI. Unlikely that his graft dysfunction is because of pyelonephritis.
Do you want to go for next transplant, second transplant, and how do you prepare such patient now?
So we will like to go for second transplant.
It's too young. Why you think unlikely should not? What makes you think we should not go for another transplant?
We should go for other transplant.
Should go for another transplant.
When do you consider transplant? Immediately? Or you want to wait? What is failing graft? And how do you taper the immunosuppression in a failing graft?
If he is a candidate for transplant within 1 year, then we will not decrease the immunosuppression. We will continue tacrolimus, MMF and steroid. If it's more than 1 year, then we will like to decrease antimetabolites or stop them and let go continue CNI and decrease the doses of steroids.
So how long we have to continue? 3 months, 6 months, 1 year?
3 months. For lifelong, back yes, 3 months.
Was that a 5-minute drive?
Now you told that the biopsy, means how do you do what the adequate biopsy? How do you differentiate between pyelonephritis and rejection? You understand? You have to do the biopsy. So how do you differentiate? You purely leave it to your pathologist or adequate biopsy in a transplant scenario?
It's 8 to 10 globes with 2 arterioles.
Yeah. Then how do you differentiate the pyelonephritis versus rejection?
Neutrophil.
You have to tell what is there.
Yeah.
I want to know how you say it is pyelonephritis, how you say it is rejection.
So rejection will patient will have tubulitis if it's TCMR.
What is Ban's classification? You tell me Ban.
I don't remember right now.
Anyone? He said no. He doesn't know. Anybody? Bam.
Loud. So that
How
people
many categories
behind
are
can
there?
also listen.
6 categories. Okay, cat 1.
First one is normal, second one is borderline or suspicious, system or
Second is ABMR.
Third one is suspicious for TCMR. The fourth one is TCMR. And fifth one is polyomavirus nephropathy. Only 5 classes.
When was the latest BAM classifications come?
2019.
What is the change with previous and the latest one?
6 to 5 category.
Regarding biopsy, when you do graft biopsy, is it possible that there is rejection or whatever something, but it was not picked up on the biopsy? What are the chances? And why can we do something to reduce that chance of false negative graft biopsy?
So there should be 2 crores. 10 crores.
Okay.
2 cores. 2 cores. You take 2 cores.
If you take 2 cores, will there be false negative or still will not be there? If you take 1 core, what will be the false negative rate? If you take 2 cores, how much it will be?
If it is 2 crores, there is more than 90% of picking up rejection.
98%.
98%.
If it's only 1 core,
60%.
no, it's not 60%. So this is there. This is very well described. Data is there. So that is there is statistically scientific reason why we should be taking 2 cores for LM. 2 core doesn't mean 1 core for LM, 1 for IF. 2 cores for LM. So still you can manage 2 cores where you can send 1 piece for IF. And there is it's if results gives that you take 1 piece from one end and the other piece from the other end. Yeah. It's around 80-85% if you take 1 core. So there's a chance that around 15% chance that you will get false negative, especially for patchy pathologies like Zika virus and maybe rejection. But if you take 2 cores, it goes to 98%. So there is only 2% chance that you will miss. So we should be doing 2 cores should be there. Time is up, sir.
Yeah, I think the time is up. I would want that, what should you take message from this presentation actually? That when you present well, be concise, be quick to give your findings, as well as have patient findings and examination also given quickly, so that you leave time for the examiner to ask you questions. If you don't know the answer to the question, say that I do not know it, so that he can go to the next question. Otherwise, he keeps on waiting for you to think. If you don't know it, tell it very quickly that you don't know it, so that more questions can be asked. They want to test you for the amount of knowledge, analysis and everything. If you don't give them time for that, then it's very likely that you will score poorly. So it's important that if you don't know something, tell that I don't know it, so that he can go to the next question itself. Or maybe he can try to squeeze an answer from you if he is very keen on knowing that that's an important answer that you should be knowing. So it's important to be quick, summarize it quickly, present it well, and positive findings on examination must not be missed. You may sometimes give important negative findings, which are important, especially. That's important, and this is what was highlighted in this presentation, that many things were not given in this presentation. So some of those, height, weight, growth, especially when the disease starts from very early, these are very, very important. And then fundamentals of nephrology you should be knowing. If you don't know the fundamentals, then the examiners will find you. You may not know esoteric things here and there, that's all, something new which has come recently or something. Nobody will punish you for that. But fundamentals are important. So that's important that those are brought out quickly, so that it gives it. So be quick. And before you come to the examiner, you must have a thought process in your mind. It's important to have thought about what is it, what are the findings like, what do I make a diagnosis, and give your diagnosis also. That's important. Quickly must give your diagnosis before you stop. Okay? And summarize after you present the full history. Okay? I think that's what I would say would be the lessons that all of you should.
And regarding this case, because invariably the VUR is a primary, secondary will be there, either in a case, long case, or in a Viva. Viva again will put in some MCUG films, and will be asked about the questions. So you read about this scheme in the VUR, primary VUR, the classification. So we didn't ask because there was lack of time classification, and you also look at the development. When what you said is later on stage may not have a reflex, because their theories have been explained. It's called spatial theory of maturation, and there are two more fancy names. I don't like. If you might be interested in all this what you call water hammer. We only look at water hammer pulse, but there is a water hammer in case of reflux also. That suggests pressure damage. And the other thing is what you said is infections. So Big Bang theory. Damage because of infections, Big Bang theory, and water hammer pulse, Berkshire Simmons, theory of maturation. All these little fancy names that also should be able to remember. And of course, as I said, history should be like from the antenatal, and then complete detailed history, including development, and then the bladder history, bladder training, and then symptoms of the avoiding symptoms. All those things should be in detail. Okay, and the transport also should cover that. Was the donor evaluation, recipient evaluation, immunological risk stratification, the induction, and then the immediate post-transplant, and of course the history. So all those things were effective in this case.
In this case, as most likely the spontaneous resolution of the reflux. So after 3 months, when the dysfunction is there, should we mention that there is a possibility of reoccurrence of reflux or anything as one of the causes?
No. It's not possible, because usually it's a neo-bladder, the ureter also, and then it is what you call anastomose to the bladder. It's a new what you call one. I don't know the terminology. So it's unlikely to have the same disease causing a reflux in the graft and then causing the VUR.
It's a completely new anastomosis, and all transplant surgeries either lead beta polytano or one of the other mechanisms of anti-reflux surgery is incorporated in the surgery by the surgeon.
The way they insert into the
so the tunneling and so on.
The only problem can be probably the bladder has not been evaluated, but it would be unusual, very, very unusual that somebody would go ahead with the transplant without evaluating the bladder. I'm sure the surgeon would want the bladder, and the nephrologist who is taking care also would evaluate the bladder prior to transplantation.
Other than just asking you also from
Yeah.
experience, we have, it is not necessary that they should have problems, right? So we have had couple of patients who definitely had PUV, who had kidney failure from this, but then by the time they came for transplant, urological evaluation was practically normal,
Yes, it can.
and post-transplant many years they have gone. So it is, that's what I believe.
Yeah,
it's
yeah,
not,
yeah.
it's not
No,
okay to
it's-
believe that
yeah,
it
yeah.
is from.
No, they may have perfectly normal bladders basically. It was that the disease developmentally, in fact that is what has been seen, is that these kidneys developmentally are poor. So that's why people started believing that surgery needs to be done in utero. So there was a period when in utero surgeries were being done because they thought post birth there is already damage which can be prevented. And then that period also they did these surgeries in utero trying to correct many things, but it failed again. So it's become quite clear now that probably these kidneys do not develop very well. Despite doing surgeries of urethral or posterior urethral valve, these kidneys do poorly because they are developmentally not. So, and the degree of dysplasia or hypoplasia will vary in individual patients. So somebody may present very early bad damage, 3 years, 4 years of age with end-stage kidney disease. Somebody may present very late, 25, 30 years later. Usually they present with hypertension and some chronic dysfunction. And many women get diagnosed during pregnancy that they have hypertension or preeclampsia, and then you find renal dysfunction and all that, and then you can get this whole history exposed actually. Yeah.
Even this after spontaneous dissolution has occurred, but whatever baseline damage must have occurred in the initial stages,
Yeah.
that can lead to CKD presentation.
Yeah, that's a secret.
If there
That's
is
what.
scarring,
Yeah.
Scarring has occurred.
then
Then there is
hyperfiltration, injury,
hyperfiltration.
and so on.
And that's a
Secondary
progressive disease, right? Yeah, then it's a progressive. UTI stopped, reflux also stopped.
And
Means
it's like
progression is multifactorial.
multifactorial.
You may have
Uncontrolled
no scars,
hypertension.
You may have no scars, but patient may become CKD. That's what sir is telling because
Yeah, yeah.
kidney is already
Hypoplastic.
There are
Hypoplastic.
5-6
Progressive.
causes.
No, it's-
I mean, it could be UTI, it can be the pressure damage, it can be because of IRGL, it can be because secondary FSGS, because dysplastic kidney or can be cyst. Sometimes they are associated. Dysplastic kidney, aplastic kidney, cystic kidney. These are associated congenital abnormality. So all these will contribute to the kidney damage.
And there are not many cases, unlike cardiology or neurology, where examination findings in nephrology become very important. But somebody who has multiple failed accesses, examination of the access is important.
And one more thing is sometimes they have neurogenic bladder,
Bladders.
and then secondarily you are, some examiners are, very particular about CIC,
Yeah.
all these things, and what will be the extra picture of neurogenic bladders. As I said, we have this, diverticulae, and then, we can have.
What
a
is the
piece-
picture of neurogenic
Yeah,
bladder on MCV?
Picture,
Anyone? In
yes,
fir tree.
or Christmas tree, you are supposed to have.
Sorry to interrupt.
Next is a short case. Presenter is Dr. Shilpa.
So we have 20 minutes.
20 minutes.
We took an hour. We took an hour.
We took an hour, yeah, I think.
It was supposed to be 40, na?
Yeah.
So it's okay. It was
No,
nice.
basically not.
okay. First case, everybody learn from that.
Good morning, everyone. I would like to present my case. He's Rudra Murthy, 46-year-old male, a banker by profession. He came for his routine post-transplant checkup, and I would like to start his history from 2017. He's hypertensive for the past 11 years on single antihypertensive. It is well controlled. In 2017, at the age of 40 years, he developed a loss of appetite with excessive fatigability associated with recurrent episodes of vomiting and pedal edema. This was present for 4 to 5 months duration, and it was progressive in nature, not responding to symptomatic treatment. And at that point of time, he gives history of frothing of urine, but there was no history of hematuria or worsening of blood pressure. There was no history, and there was history of progressive oliguria. There was no history of any recurrent UTI in the past, no history of any prolonged fever, joint pains, joint symptoms or rash, no history of any hearing or visual deficit. And he did not have any history of any indigenous medication. On evaluation for these symptoms, he was told to have severe anemia and severe renal impairment, and was explained the need for renal replacement therapy. following which he was initiated on dialysis via right internal jugular venous catheter, and after which his left radiocephalic fistula was fashioned, and he continued thrice per week maintenance hemodialysis. During the dialysis, he did not have any history of catheter-related infections or any intradialytic complications like hypotension. He did not have any coronary event. However, he had history of recurrent fever, and he told he had fluid in the lungs, which was evaluated, and he took ATT for 1 year. And after that, after 3 months of stopping ATT, he underwent a live-related transplant with a younger brother as the donor, and it was ABO compatible. Blood group was A. However, he doesn't remember the details regarding HLA matching or the cross match. There is also no history of any costly injection prior to the transplant, and his total dialysis vintage was around 2 years. Immediate post-transplant course was uneventful, and at discharge it was 1 milligram per deciliter on post-op day 8.
Urine output during dialysis prior to transplantation?
Prior to transplant, sir?
Residual urine.
Forgot. Immediate post-transplant was uneventful, and at discharge it was 1 milligram on post-op day 8, and he did not have any surgical complications or wound infection. At 3 months post-transplant, he had asymptomatic graft dysfunction. His creatinine was 1.3 milligram, and he said he was compliant with all the medications. At that point, biopsy was done, and he said that his tacrolimus level was checked, it was less, and his drug was optimized, and he was conveyed that biopsy did not have any signs of rejection. However, at 6 months post-transplant, again he had a...
biopsy did not have signs of rejection. His TAC was increased.
TAC level was low, but he did not have any... He told that biopsy did not have rejection, but TAC level was...
The thing that was done was his TAC dose was...
TAC dose was optimized, he said. And at 6... Increased. Tacrolimus... It improved according to him. At 6 months post-transplant, again there was rise in the creatinine. At this point he told it was 1.6 milligram. Again he was asymptomatic at this time. He did not have any complaints of fever, lower urinary tract infection or any diarrhea. Again he underwent a graft biopsy, and he told that he was told that he has some viral infection. Initially it was present in the urine, and his immunosuppression was modified. His MMF dose, he said, was decreased, and he was added on some tablet called Leflon. Even despite that, his creatinine worsened, so they completely stopped his MMF and they continued that Leflon. And he also said he received 2 costly injections at that point of time. And initially the infection was present in the urine. They said it was also later found to be in the blood. After the treatment, he said he was told he was treated of the infection, and post that he has a stable graft function at around 1.6 to 1.8 milligram, and also during the course he was detected to have diabetes, and presently he is on oral hypoglycemics, well controlled. So presently he is 4 years, 2 months post-transplant with a stable graft function of 1.6 to 1.8 milligrams. Past history, he is hypertensive for the past 11 years, no history of any coronary artery disease or no history of any cerebrovascular accident. No, so that's it. So to summarize, here is a 46-year-old male with a history of hypertension for the past 11 years and chronic kidney disease stage 5, secondary probability to see chronic glomerulonephritis, probable IgA nephropathy. He underwent a live-related kidney transplant, ABO compatible in 2019, and he presented with a history of asymptomatic graft dysfunction 6 months post-transplant, secondary to viral infection, probable BKV, presently treated and having stable graft function.
So what was the injection that was given to him? What do you guess? Even if he didn't know what the injection was, you can make a reasonable guess what this injection
IVIG, sir.
IVIG. Okay.
What is the origin of BK virus? You have a patient with BK virus nephropathy. Where does it come from?
It is from the donor graft. I mean the graft itself in the renal uroepithelium and the.
But is this virus present in the normal
Yes, sir.
population?
Normal population, yes, sir.
So it's present in the normal. So it could be even from the recipient itself, from the urine, isn't it? Like cytomegalovirus. If you have a CMV IgG which is positive, so you would have had a CMV exposure sometimes during your early young life. And the CMV IgG is positive. So CMV remains.
But here in BKV they say it's only because of the donor infection which is getting reactivated and producing graft dysfunction.
There is some theory on that, but not necessarily so. Not necessarily. There are a lot of people who keep on testing donor before they give kidneys. They test urine of donors to find out if this is BK or BKV IgG in the PCRs, in the donors also. Some people, even Hariharan had presented a paper on looking at some of this, but this data is very, very controversial. So CMV could get activated from the recipient. It could be that the donor kidney may be the one which would be. So it comes somewhere from, either from the surgery. But what's the primary cause of this? Why does a patient with kidney disease, kidney transplantation get this?
Mainly because of immunosuppression, immunosuppression.
So the viruses
That gets reactivated.
Reactivated. So there is a reactivation of these viruses, probably. Either you can still consider whether they are in the donor or in the recipient source, but they get reactivated because of immunosuppression.
Which particular immunosuppressant is particularly been implicated?
Anti-proliferative.
Which calcineurin inhibitor? Tacrolimus. The risk is 5 times higher with tacrolimus as compared to cyclosporine.
Yeah, it also started coming in during the time when tacrolimus started coming in. But people believe that it's the net immunosuppression actually, which is it. And these have been described even in people who have not taken tacrolimus but have been on cyclosporine also. And many other transplants, lung transplants and all, although initially it was believed that it happens mostly in kidney transplantation and doesn't happen as much.
I've seen in bone marrow.
But you have seen now BK virus now even in, so there is, it's probably highest in kidney transplant recipients, probably because we intervene with the uroepithelium during the process of surgery itself. So some reactivation there as well. But primary thought process now is that it's because of over immunosuppression in that particular individual.
So a kidney biopsy was done in him. The first time it was done and his TAC was increased, but they said there was no rejection. And then after that, the second time around biopsy was done and it was
BK
virus. So suppose you, and in the previous case also madam said that, or Dr. Srijit said that you can miss BK virus when if your biopsy is in. So what can you do if you just don't get BK virus in biopsy, but you're suspecting, you're not found anything else, no rejection, no CNI toxicity, so maybe this is BK virus.
In the biopsy, the medulla should be particularly looked at because.
Yeah, but once you've done the biopsy, you can't do anything. If it's got medulla, fine. If it doesn't have, it doesn't have.
What are the other ways, sir?
The IHC, SV40.
What is SV40?
This is it is antigen. Simian virus antigen.
So what are you staining for? So it's a shared antigen with the BK virus. And it definitely picks up, if you see a biopsy in which even there is BKV, you see the BKV by light microscopy in a few tubules. You do a SV40 staining and many more tubules light up. So if you have a suspicion, always do an SV40. That's it.
No, in fact, in a biopsy, you should tell your pathologist, especially if you don't find, you have graft dysfunction and you don't find signs of rejection, then all the more reason to tell him that your pathologist should itself, our pathologist is now trained into this, they will do SV40, irrespective of whether they look it on light microscopy.
At all. And it's,
so
you
they
don't
do
need
an
a second
SV40.
piece. It's on
And subsequent to that, in this patient, I think I would have done a TAC level at that point of time and SV40 and even done a BK virus at that point. If you don't know the cause, because on the biopsy you don't find anything and you find that the TAC levels were low. Ordinarily with low TAC levels I would have expected a biopsy to show rejection. But you don't find that, then and you increase the tacrolimus. Now I feel that increasing the tacrolimus probably aggravated. He probably had BK virus at that point of time also. And with an increased TAC, now he expresses full-blown BK virus. So I think that's most likely
necessary to do that SV40 because BK virus, even otherwise, you will get interstitial nephritis and tubulitis may not be there, but you've not found viral inclusion. Somebody might be tempted to think that it's a rejection again, where I missed the tubulitis and increase the immunity. Early days that happens.
No, this happens very often that people usually tend to make a diagnosis of an acute rejection because they haven't done BK virus. So I think these must be done in every. So whenever you have a pathologist, doctor, tell him that you should do this. You will have to tell him that you must get this done. And it should be in the biopsy protocol itself.
How do you make a diagnosis of BK virus nephropathy?
In the presence of viremia and biopsy showing inclusion bodies.
Is it possible to make a diagnosis without biopsy?
Viremia is itself considered as
you checked it is 1,000.
10,000 to the power of 4. 10 to the power of 4.
That's 10,000.
The 10,000.
Viremia is, of course, nephropathy to diagnose is possible without biopsy.
Urine.
What is the sensitivity of decoy cells?
The sensitivity is, specificity is 30%, sensitivity is 100%.
No, it's the other way around. The sensitivity of the decoy cells is about 30 to 40%. But what else can you do then, which has a much better sensitivity, even more sometimes than biopsy?
In urine.
In urine.
Hoffen.
What is Hoffen?
It is the viral aggregates and the in the urine along with the TAM phosphol protein.
How do you see it?
In the negative staining electron microscopy.
So that has, I think, a 90% plus.
Yeah, I think you should, whenever you have BK virus suspicion, you should do a BK virus PCR. Fortunately, these have become cheaper now. They were available. They are good. They're becoming good also. So you can quantify what is the viremia load, and then if the viremia load is more than 1,000, I think they become specific. This tells you about the immunosuppression. So you need to reduce the immunosuppression, as I was talking yesterday also, that this is a cry from the body that my immunosuppression is high. So you also have to understand that we do not have a good method of knowing what should be the immunosuppression in each individual. At the moment we do rule of the thumb, milligram per kilogram. We don't know whether that is the best method of giving immunosuppression. Mycophenolate mofetil, we don't even know whether we need. So we give rule of the thumb. Every individual probably requires less or more. We don't have that method at the moment. So if you have increased viral infections, then a good physician will know it. If you have increased viral infections, you know that your immunosuppression is more. If you are getting more rejections, then you know that your immunosuppression is low. So how does one understand whether you are where are you? So the best way would be if you could have a measure of how much immunosuppression you give. So how would one know it in a post-transplant period? Would be to look for BK virus and cytomegalovirus. The only problem is that it adds cost to the. So when would you do it? Usual time period is 3 months to 1 year. 3 months to 1 year is the peak period for BK virus infection. 6 months to 1 year is also for cytomegalovirus. So you could do it once at least in 3 months or 6 months CMV over a BK virus. If these are negative, then you know that you're not over immunosuppressed. And if you haven't had a rejection, then, or the kidney functions are better, you are okay as far as tacrolimus. Obviously, there is a method to monitor at least, so you should be in the therapeutic range. And mycophenolate mofetil, depending on the leukocyte count and the tolerance, GI tolerance and other things, you determine that. So you could do this. I have started doing this, I said it yesterday also. I do now screening for antibodies at the end of about a year or so, to look for if you are on the, because at the end of 1 year there is a tendency to reduce immunosuppression. You want to get mycophenolate mofetil to around 360 milligram twice in most patients, and then you would want, maybe you could go further down on tacrolimus. That's when you might see these antibodies coming up. So I would do an antibody. If the antibody is alright and the viruses are alright, I don't do too much change. But if one of them is present, then obviously I will have to cut down. So this may be an indirect monitor. I don't think this is a perfect monitor for this, but probably a reasonable, cost-effective method by which you might have some measure of how much are you on that path, where are you. You need a balance between immunosuppression in such a fashion that you are preventing rejections and you are also not causing more infections in these patients. And the two infections we tell you about this is cytomegalovirus and BKV. Pardon? Antibodies is screening antibodies for anti-HLA antibodies. Donor-specific antibodies by the screening, DSA screening. So Luminex screening test, which costs around 5,000 rupees. So that's the way. So how would you treat this patient?
First step is reduction of immunosuppression, stopping of MMF and...
I think, see, this patient, as you said, they halved the dose and then it still didn't work, then they had to stop it. So I think the best thing to do in this situation would be, if your TAC levels are okay, I would stop mycophenolate.
And you using leflunomide, they did use leflunomide.
They use leflunomide.
Which is also...
Yeah, is an immunosuppressive agent. Now, I am not so sure about the value of leflunomide, that can be questioned, but there are people who would argue on that and that they might use leflunomide. But if you use leflunomide, then I think it's absolutely necessary to reduce mycophenolate mofetil or don't reduce it, stop mycophenolate.
You are in an ideal scenario. How you would have, one thing we are told in the first biopsy, we would have done an SP40. Other way of identifying early what to get.
Preemptive monitoring BKV serology monthly in the first 6 months and then thrice monthly in the next 6 months.
How would you monitor? Do a urinary one or a blood one?
So blood piece here.
Yeah, people have done urinary measurement of as a monitor for looking for urea, but unfortunately the specificity is still poor in this, and therefore making a diagnosis of this as a monitor for you to help whether you should reduce immunosuppression or not has not been found to be very useful. So probably the best method would be to do a PCR in the blood itself, which has been found to be, although there are some centers which probably it's all center specific. See, there is, in transplant there is another thing which is happening, is basically that people are using, every person has a method of his own or her own. He can swear by 2.5 milligrams of steroid, 5 milligrams, 7.5. So everybody has a method of their own and they will swear by it. And same is with making diagnosis of BK virus. Many people use, in England, I think in UK they use urea as a marker for measurement of immunosuppression and whether they would go up or down. But mostly in other centers, US and the rest of the world, probably viremia is what is looked at. So, but as long as you know that you could use either of them, then it is. And then viruria, you need to be very good, lab must be very good in measuring viruria quantitatively.
Couple of things before, you mentioned something called, something like progressive oliguria. So I was not sure what exactly you meant by that. Progressive oliguria.
Oliguria was present. As his urine output.
Do you know it was oliguria? Because oliguria is a Okay, so you meant reduce urine
Reduced urine
output.
output.
I would say better to use reduce urine output rather than progressive oliguria. The other one issue which
Progressive oliguria, in my opinion, would be oliguria to end urea.
So the other thing, this patient, I think, which was relevant to this patient was patient had probably tuberculosis and patient was on ATT. So what is your this views on how common is TB in dialysis population, and when should we? It appears that the ATT was completed and another 3 months and then transplant was done. So is that the right way to do it, or is it possible if somebody started on ATT to do transplant before ATT is over?
It is recommended to complete your ATT and then
Yeah, I think from the induction phase, the first 3 months of giving the induction phase, once that is done, then we can proceed to the transplant.
Provided patient has responded.
Yeah, responded and continue the maintenance phase.
Okay, all right.
Yeah, but she's right. If you read the books, they will tell you to complete the ATT before transplantation. Unfortunately, it's the fault of us that we haven't produced enough literature of our own. Most of us, you can see all the examiners nodding their head, that they would not wait for 1 year, because none of our patients, I think we can make them wait for. So we have all done transplants, giving them 6 to 8 weeks or sometimes 3 months of treatment, and they seem to have recovered, and then you continue the ATT. But in the literature, and as per the guidelines also, you will see that they would want that treatment should be completed before you do the transplant. And I think I was sitting in the guidelines for KDIGO on this, and it was such a huge fight. 3 days it took us to make a decision, and then the final line added was that local guidelines may be prevalent and they should be considered. That was the only line which they agreed to add, that local guidelines, and you will see it in the guidelines that this is why it's so difficult to get this. So we need to produce that data. I think that's something which we haven't published that well on that.
Our protocol is 4 weeks of IDT, patient is doing well.
Yeah, good. Oh, that's what I said.
My side, I want to tell you, in any transplant case, this is for the primary disease. So you are told something about that most likely IgA. Then you are doing a transplant, you should always tell us about vaccination. Your first column is the and high risk or low risk. Whatever is there, you have to tell me. Like whether he has any exposure to blood, you are negative, you should tell us.
Time is up.
He's presented with features of volume overload with
Proceed, you have to keep asking. Examination for you.
examination
Or
file.
if you don't want any further, you can tell her to go on.
Go on.
Go on.
Yeah.
Anasarca.
So there is no return.
No retinol. Blood pressure is 190 by 100. Go on now.
What else you want? Anything else you want? Is enough? This examination is enough, or you want some more details? Just imagine you are the consultant and she is your registrar. She is presenting to you. Either you are satisfied with this, or you would like to ask something else. So that's the idea of board round. Right?
Systemic examination.
Comes.
Yep. Go back. Yeah. Systemic examination. Anything particular you want to mention? Nothing. So,
Now, what do you keep in your mind in systemic examination? What do you want to know? Patient has anasarca,
Cardiac exam. The apex lead. Heaving. Cardiomegaly. Ventricular hypertension.
Yes.
They are not thinking aortic stenosis. End of the last slide, it was written differential diagnosis. Now we have both history and examination. What do you think?
So he's a
Presented with features of volume overload, probably nephrotic syndrome.
It's a known diabetic and hypertensive. Other things that I would like to rule out is cardiac disease and liver disease.
But here we are interested in his renal disease. So what do you think it is?
Probably. Yes, ma'am.
Quite different.
Yes.
You have a diabetic who's quite a long time, 50 years, and a type 2 probably it is even longer. It's never an acute presentation in type 2. So there is a long duration of diabetes. Now leg swelling, probably proteinuria, we will find out. Very high blood pressure and no retention.
So,
What you want to do next?
What investigation?
What investigation?
see urine routine,
Okay.
renal functions.
This is the
So you have it there.
HP is 10.3, creatinine is 1.3, serum albumin is 2.2.
interpret it. Rather than telling you.
So anemia is there, renal functions are close to normal. There's hypoalbuminemia. Urine routine is showing nephrotic range proteinuria 3+ with 8 to 10 pus cells and 3 to 5 RBCs. Urine protein creatinine ratio is 16. Complements are normal. On ultrasound abdomen, normal size kidneys with minimal ascites is there. So, nephrotic syndrome in a patient with diabetes who doesn't have diabetic retinopathy. So, I would want to go for a kidney biopsy.
What all features here are saying to us non-diabetic renal disease?
One, activity on nephrotic range proteinuria, then active in diabetes also. Absence of diabetic retinopathy, then pus cells in urine, also RBCs, significant pus cells and RBCs in urine. Hypertension,
Hypertension is part of diabetes.
part of diabetes.
Means that in this case, like you were telling RBC is 3 to 5. You will biopsy in all diabetic fellows with microscopic or chemistry. Is it an indication for it? If all other things suits for a diabetic nephropathy, do you really biopsy or?
To your mind, what situations you will biopsy a type?
Sir, very rapid deterioration in renal function.
Right.
Unexplained nephrotic range proteinuria,
Yes.
which is there.
No,
And
nephrotic range proteinuria is there. That alone we cannot use as a
Unexplained, rather than that, what you want to say?
in the absence of other end organ damages.
No, not like that. Madam has told us. Not unexplained, what you tell?
Rapid onset, abrupt onset.
New onset.
New onset, and the duration is long, 15 to 20 years, and for the first time you're getting proteinuria.
Any other indication?
Retinopathy,
What do you mean by active symptom?
presence of RBCs and pus cells in urine.
Any RBC that can occur
Proliferation happening in the
pyelonephritis,
kidneys.
or urinary tract infection also you get RBC in pus cells. So that alone you cannot say it's an active symptom. When you say active symptom, what do you mean?
Casts.
If you don't find RBC cast, with the RBC, can you say there is an active symptom? Is there anything there indicating that will be an active?
In other words, this hematuria,
Few RBCs, 3 to 5
3
RBCs.
to 5 RBCs could have come from the blood. How do you know they are coming from the blood?
Dysmorphic RBCs.
Or acanthocytes. Those things. So when you say active sediment, you are implying that there is an RBC cast. You cannot find audibly.
Dysmorphic
RBCs are
RBCs.
there also, it's suggestive.
How do you look for dysmorphic RBCs?
Phase contrast
You don't have
microscopy.
it. Lab field, no? What? MCV on urine. Rack the condenser down. Reduce the light by putting the condenser as low down.
Can RBCs be present in somebody with diabetic nephropathy?
Yes.
Yeah. 10 to 20% of patients can have some RBCs. So that doesn't make it an active cell. So that's what.
Other indications you have to tell. You told only 2 or 3. For kidney biopsy and diabetic patients. Indications.
No, tell us.
Other
Indications for that.
Other indications are
Others? Yeah.
Rapid.
one.
Which is like 190.
Is there anything else here which says that may not be a diabetic? Yes, sir, that we already said, apart from what we said. In investigations.
High quality. Usually doesn't happen.
What about anemia? Is it common? With the normal resistance, near normal resistance.
Anemia?
It's something like a CKD system.
But at what GFR does anemia?
Anemia.
Yeah. And at 1.3, I don't think this patient's GFR will be that.
If you are telling, you are thinking a non-diabetic kidney disease, any other test, like immune test you want to do in this case?
PLA2. ANA.
Why do you want to do that? Why do you want to do PLA2?
So he has a nephrotic syndrome with hypoalbuminemia and nephrotic range proteinuria. So apart from membranous, and 64 years old, so membranous nephropathy is possible.
So there is some controversy today whether serum PLA2R can replace a kidney biopsy in the presence that you may not do a biopsy. You get a high PLA2. However, there is one point is that chronicity on the biopsy is something very useful, which PLA2R is the same level.
Screening for malignancies. Still, ma'am, we would still want to screen.
Okay. One more? 20 minutes.
10 minutes. 10 minutes.
10 minutes.
So the biopsy
Answer has been given.
So there is nothing further.
So means you had FSGS also in your mind or you didn't have?
Is there anything in this?
Lower down.
There is something else in the biopsy, but besides the FSGS, if anyone wants to comment. Yeah, someone said it. Articular. There's articular hypertension. Lot of cases. Whichever articular, there is extensive articular hypertension.
What is the characteristic in diabetes as far as arterial hypertension is concerned? The characteristic. Because he also has hypertension also.
Yeah. Which one?
Different.
If you have a biopsy, can you distinguish when you see a globulus, which is the efferent and which is the efferent?
Can you distinguish or not?
Efferent starts within the glomerulus and can extend.
Inside the bronchi. This is the glomerular tuft, capillary tuft.
There is an article here which is showing ileosis, which is efferent or efferent.
Correct. Why? Proximity. The thing, proximity on the depends on how the cut of
goes.
the microtome has gone.
There's no distinct now.
Yes.
If the efferent comes as a nice full circle next to the glomerulus, the efferent will wind around it. It winds around the glomerulus. That one is the efferent. This is the mesangial stalk here. This is the efferent arteriole. This is the segment of sclerosis here and here. And the efferent, if it is at all, it would maybe, this is partial cut, I can't say for sure, cut of the efferent. The efferent, because it starts off from the peritubular capillaries, it winds around the glomerulus, whereas the efferent is as a nice tangential surface.
Can still be a diabetic lung, maybe secondary due to hyperfiltration injury, adaptive changes.
What are the other changes of diabetic nephropathy on the biopsy?
Mesangial widening, KW lesion.
By the way, which stain is this? When we talk about pass. It's stain.
Stop here. Next time. 10 minutes. 10 minutes. 10 minutes. Probably 14 minutes. So let's see the time. Next is.
This is a long case.
Long case.
Dr. Sumika Patel. Good afternoon.
My patient is 25-year-old female, Miss AB, residing at Chennai, science graduate by education, Hindu by religion, unmarried and informant herself, and she came for her routine follow-up after renal transplant. History of presenting illness, I would like to date back my history 20 years back. In 2002, when patient was at the age of 5 years, she was admitted to the hospital with a history of high-grade fever and vomiting and subabdominal swelling in the right side, and there was no history of any dysuria, increased urinary frequency or constipation or any other complaint. And on further evaluation, she was diagnosed with urinary tract infection, and on further evaluation in that admission only, she was informed that her left kidney was non-functioning, and on the right side there was swelling in the right kidney with the ureter. So after some antibiotics in the same admission, she underwent some procedure on the bladder. That was at the age of 4.5 years. And after that procedure, she was doing well. And after at the age of 15 years, which is in 2013, again she was admitted with the history of high-grade fever, nausea, vomiting, sudden onset of decreased urine output with the right-sided abdominal swelling, which was associated with intermittent severe pain in the flank region. and there was also fullness in the right-sided flank region. For the same, she was admitted and she underwent stent insertion procedure, which was tried from the urethra, but it was not successful. That's why she was told that it was done from the back of her right side. And then she was told that she used to undergo the stent changing procedure every 6 months for next 2 to 3 years. And then she was lost to follow up for 1 year, and stent was in situ at that time. And later in 2016, she had again history of high grade fever, decreased urine output, nausea, vomiting. And at that time, after further evaluation, she was told that she again underwent some surgical procedure on the bladder. And at that time, she was remembering that her creatinine was around 1.5. After that surgery, she was in regular follow-up, and then from 2016 to 2019, so over next 3 years, her creatinine was slowly increasing. She was telling from 2, it was slowly increasing. In 2019, it went up to 6 creatinine. And at that time, she was advised for renal replacement therapy and need for AV fistula preparation. Though she underwent AV fistula procedure in 2019 in December, but 2 weeks later she had nausea and vomiting. So she was admitted, and at that time her creatinine, she was remembering that it was 8. So she was started with the renal replacement therapy in the form of hemodialysis, which was done from the left-sided tunnel catheter, as fistula was just made 2 weeks before this episode. And after 7 to 8 weeks of hemodialysis from the tunnel catheter, then it was changed to the AV access, and later on tunnel catheter was removed. She remembered that she was right on the right upper limb forearm AV fistula, radiocephalic fistula. She remembered that her urine output was more than 1 liter per day, and she was undergoing hemodialysis 2 times a week, 4 hours of duration, and she was having intermittently, occasionally low BP and low sugar. Apart from that, she was tolerating that procedure very well, and she was planned for renal transplant, but it got delayed due to COVID in 2020. And then in January 2022, she had history of low-grade fever with history of weight loss over 1 month. And on further evaluation, she was diagnosed with tuberculosis, and for that she was started on anti-TB medicines, which she has completed for 6 months, and which was completed in July 2022. And after that, again she was planned for renal transplant. So with the mother being donor, she was evaluated for the renal transplant, and she underwent, before the transplant, she underwent bilateral nephrectomy, which was done in September 2022, as she was told that for the preparation of transplant. And she underwent transplant in January 2023, which was ABO compatible living related donor transplant. She was remembering that her urine output was very good after 2 days of surgery, and her creatinine was around 0.8. But on the day 7th day post-operatively, she again had a fever, and she found to have urinary tract infection on the post-op day 6 of the transplant. And then on the post-op day 10, she had a sudden onset right-sided lower limb swelling, and which later on she was found to have some clot in the veins, in the lower limb vein, and for that she was started on first IV anticoagulant, and then it was later converted to oral anticoagulant. After 1 month of then she was discharged with her routine medications and oral anticoagulant. After 1 month of discharge, she had history of decreased urine output, and there was some swelling over the surgical site, and there was some yellowish oozing from the incisional site. and she remembered that during that episode her creatinine went up to 1.5, and in that after that admission she underwent some stent insertion, and there was some drainage tube was inserted from the outside also. And in March, later on in March 2023, she again had history of fever with burning micturition, and for that urine culture was done. It was positive, and she was treated with appropriate antibiotic for 7 days of IV and then 7 days of oral antibiotic. Now at present, she, as we have discussed, she came for her routine follow-up, and there was no history of fever, vomiting, or she is passing at present around 3 to 4 liters of urine, and she is on her routine transplant medication, which is including tacrolimus, MMF, and steroids with multivitamins, with oral anticoagulants, and yeah, that's it. And there was no history of any hypertension or diabetes or any cardiac issue during this course. And on family history, she is born of non-consanguineous marriage, and she is having one younger brother which is 6 years younger than hers, and he is healthy, he is not having any issue. In the birth history, there was no proper antenatal history was available, and there was no proper actually antenatal evaluation in the mother also. She was full-term normal delivery, 3 kg weight, and that first 4 years were okay. There was no history of any admission or any ICU admission or nothing. And she has completed her vaccination till now, and last dose of COVID-19 vaccination was done in 2022 before 1 year of transplant. So I would like to conclude my history. So 25-year-old female who is having urinary tract infection at the age of 4 years, and at that time she was diagnosed that her left-sided non-functioning kidney with right-sided swelling in the kidney and ureter, and for that she underwent some procedure on the bladder. After that admission, around 10 years she was doing good. At the age of 15 years, she was again having history of fever and decreased urine output, and at that time it was like again she underwent a stent procedure which was changed every 6 monthly, but in between that she lost to follow up for 1 year, and then it got infected. She again had fever. So at that, after in that admission, she underwent again some surgery on the bladder only, and after that she was in regular follow up, but later on then she was like her creatinine was creeping up from 2 to 6 over the period of 3 to 4 years. And then in 2019 she progressed to end-stage renal disease and started with the hemodialysis. First AV fistula preparation was done, but started with the hemodialysis after 2 weeks of AV fistula preparation from the left-sided IJV tunnel catheter. Later on it was started from the AV fistula. After 2 to 3 years of dialysis, in between that she had one lymph node tuberculosis was diagnosed, and for that she took AKT.
Shorter.
Yeah. So she took AKT, and then she underwent renal transplant in January 2023. And after renal transplant, she had one episode of UTI during the admission only, and deep vein thrombosis. And after discharge, there was collection over that transplanted kidney, and later on one episode of UTI. And now she came for a follow-up, routine follow-up.
Diagnosis?
My chronic kidney disease, transplant, underlying native kidney disease would be chronic tubulointerstitial nephritis, probable etiology being bilateral high-grade vesico-ureteral reflux, plus underlying congenital anomalies of kidney and urinary tract, and which progressed to ESRD, and then she underwent dialysis, and then it was got transplanted, and after transplant she is having
diagnosis should We already
Yeah,
diagnosed
okay.
not again
Yeah, okay.
summary. So you said CKD.
CKD, underlying etiology being chronic tubulointerstitial disease, secondary to bilateral vesico-ureter reflux.
Why do you think this is reflux?
Because when she was first time presented at the age of 4 years, at that time she had urinary tract infection, and there was some she was like having swelling in the right sided flank region. So it could be, but and then left sided.
Why would a vesico-ureteric reflux give rise to a right-sided swelling?
No sir, a left sided kidney, she was told that it was the non-functioning. So maybe underlying congenital anomalies of urinary tract plus reflux could be there.
Yeah, the same as with the previous case. If you think it's reflux, then questions like about bladder control,
There was no,
nocturnal
yeah.
diuresis, these would be important to know.
Yes sir, but there was no no bladder issue or no constipation or any incontinence history till that first episode of UTI. And after that also she was not having any history of that.
So supposing you were evaluating this patient at that time, the patient has come with the with the
UTI.
urinary tract infection, and I don't know what the right-sided swelling was and a non-functioning. I don't know again
Yeah,
how
yes, yes.
that non-functioning was. How did they know it is non-functioning?
Actually she was not aware about.
Okay.
Yeah.
So somebody has a non-functioning left-sided kidney, a right-sided kidney which probably had pyelonephritis. What would be your?
So first I would like to start the treatment with empirical antibiotic, and after sending the cultures. Then in that patient, in children, I would like to do first sonography of the kidneys, and if there is any anomaly, as we are discussing that there was some left sided non-functioning, then after maybe 2 to 3 weeks of antibiotic, I would like to, or in that admission only, I would like to do micturating cystourethrogram, or and then later on after.
It was not done.
She was not aware about, because her mother was not present, and at the age of 4 years she was like not recollecting. And after that settling of that episode of infection, I would like to do DMSS scan also, as in the USG if it is showing left-sided non-function or a small kidney, then I would like to see the function, differential function, and also the
DMSA won't tell you this.
yeah sir, sorry. So the scarring and all on the right side, so that further approach I can like decide according
When
to
will
that.
you do the MSA? After the infection?
It is said that after completion of antibiotic, at least 2 to 3 weeks, if we are looking for 3 months for scar. Yeah, scar. If we are looking for scar, it is 3 to 6 months.
Why do you wait?
So if acute infection is there, so we because sometimes after resolution of infection that scar is not there, so specifically to
The reason is the scar is a cold area on a DNB.
Yeah.
And infected kidneys also show
Also
as
show.
cold area.
So to avoid that false
So you cannot
interpretation.
distinguish this.
So you want to do VUR, when will you do it?
Sorry,
After
sir?
the infection you want to do a VUR, when will you do the VUR?
Ideally towards the end of treatment when she is on antibiotic, because in VUR, in MCOG also we will require a prophylactic like it should be done under cover of antibiotic. So that way we can plan. Yeah.
Nobody will put a stent.
Yeah, sir. Actually, yeah. I asked specifically.
It made me think, and also you are coming with a swelling is less, so made me think whether this is
Some of
PU junction.
obstruction.
They have
And
put a
that is why I
PCN, anterograde that.
anterograde they put a stent.
I was thinking whether you had stenosis, and that means
history was-
first one they had a reimplantation, then had a stenosis. You have to correlate the things when you are telling. That will be ideal.
But you said that ureters are also dilated, no? In your
Sorry,
history,
sir?
in your history you said the kidney and the
ureter were
Ureters, yeah.
dilated.
So that was at the age of 4 years, and then 10 years she was doing okay with after that procedure, and then later on she had this maybe some, again there was pain and swelling.
So do you think
and
the PCN and the what do you call it, stenting helped her in any way?
I think no. I think because repeatedly doing stenting will be
So what is the
more
role of PCN stenting? When do you use the PCN?
in acute condition whenever there
In
is
what condition?
if patient is having renal failure or there is distal obstruction.
All renal
Yeah.
failure are not being stenting.
So distal obstruction, then we should try PCN and then antegrade stent.
So only when there is obstruction, that is only.
I'm assuming that they would have done an uretary cream panel and gone to stricture.
So I think that was the second episode must be because they could not do yeah. So that's why they have.
Third one it may be PUG also. If the
yes,
partial has become complete, we don't.
Because she was not aware about any investigation, like specific investigation.
She went, they inserted her left, why did she have a left tunnel catheter?
Yeah, that so basically she underwent right-sided AV fistula and she was told that as it is on the right. Yeah, but she is right-handed, but she was told by the surgeon that if we will do on your right hand, it will be better to it will get early maturation or it was told like that, and
Maybe
so
she did not have good vascular.
yeah, so that's why it was underwent right-sided, so they put the left-sided tunnel catheter.
So is that a norm?
Is it correct or wrong?
Ideally, yes, it is correct. We should avoid this same side of vessels for central venous catheter on the site of fistula.
When is it a problem? If you put it on the same side, when will it cause a problem?
So if there is central obstruction, then the fistula will also be hampered in that.
Common with upper arm fistula. Radiocephalic AV
Yes,
fistula
yes, it is less.
Less likely to, like an occult stenosis, if you do an upper arm fistula and you increase the venous return, an upper arm fistula can increase the venous return by 20% of the cardiac output. That's when the stenosis becomes manifest. But a radiocephalic AV fistula has a flow of how much?
Sorry, sir?
How much is the flow in a radiocephalic AV fistula?
Around 600 to 800.
800 is very high.
400 to 600.
So it will not usually produce. What can be the problem with a left-sided tunnel?
The flow issue in the catheter also, because there are two curves and the long course, so they has to pass. Yeah,
three actually.
Yeah, three.
Three curves actually, and
inside the one.
is it also more prone to stenosis?
Yeah, it is more prone because of that that curves and catheter interaction on that side.
The force of the catheter is such that a part of the catheter always lies in contact with the left innominate vein.
Yes.
That is where it shears off the endothelium and eventually results in a stenosis. So whereas the right side is a straight course and the catheter is invariably in the lumen of the vein. Whereas the left side, as it takes that curve, it invariably comes in contact.
So going back to this patient, did she have hypertension at any time?
No, anytime she was not. She was very sure that even on the dialysis or before starting dialysis, she did not have any hypertension,
So
and it used to.
In a reflux situation, is that usual?
No, generally 20 to 30% patient in reflux disease have hypertension.
Once they develop reflux, what is reflux nephropathy?
So reflux nephropathy is secondary to the reflux or secondary to underlying chronic tubulointerstitial nephritis, secondary to maybe reflux of the urine from the bladder.
That's all. What is reflux nephropathy? You are talking EUR is one thing, reflux nephropathy is something else. Is reflux nephropathy a tubulointerstitial disease or a glomerular disease?
So whenever that kidney renal parenchymal damage is there, secondary to this reflux underlying other anomalies or any reflux, then it is called reflux nephropathy.
No, it's not. What is reflux nephropathy? Actually, you should read the original definition, descriptions of reflux nephropathy. It's not the case. What happens in reflux nephropathy is different from EUR itself.
Yes, sir.
EUR is what you described. There is a reflux of the progressive damage to the kidney due to the reflux. As a result of that, what will happen to the kidney?
So
when there is chronic damage and patchy, what will happen to the kidney?
glomerulosclerosis, space
What is that called?
interstitial.
What is that called?
Secondary FSGS, secondary FSGS.
So that is reflux nephropathy. When
Yes,
a patient develops secondary FSGS and you detect that by presence of hypertension, proteinuria, and that is the
And
difference.
then
That's why reflux nephropathy is a glomerular disease, not tubular. That's very peculiar in this patient. You say reflux, not developing a glomerular disease and going on for that. That means what?
It is not It is more likely chronic tubulointerstitial disease.
Why? That's because probably already there's only some dysplasia in the kidneys to begin with. That's why. So
Yes,
there is an additional, it's much more. So VUR, is it genetic or is it sporadic?
It is an underlying genetic predisposition. There are some genetic mutation. Most common is PEX2 WNT mutation, and on that environmental factor and other factors can precipitate. Because siblings have, like, there are higher chances of having VUR in the siblings also. So it is telling that some genetic correlation is there.
So supposing you had treated the first episode of paralysis, unfortunately it was only at 4 years of age. No?
Yes, sir.
So at that time you have treated the episode of paralysis. What are the how will you follow up? You have done the MCU, you have demonstrated the flux. You have done the ultrasound, you have shown bilateral necrosis. You did the DMSA and you have shown scars. Now what will you do?
Now we have to treat other, like if she is having other complications, like as we have discussed hypertension, then we have to treat it. And then if it is slowly progressive CKD, then other complications of CKD, like if anemia is there, because this patient can have more higher chances of anemia.
What was the presentation she had at that time?
When, sir?
The first presentation.
First presentation was fever and vomiting.
So in terms of that.
Yeah, and we have chronic antimicrobial prophylaxis also if required.
Would you do a reflux surgery for this patient?
For this patient, yes, I would like to.
You are showing a high grade reflux, grade 5 reflux.
Yeah.
Can you grade reflux? How do you grade reflux?
So that is based on international reflux study. There are 5 grades of reflux, which is done by MCUG. So first grade is only urine is in the ureter, but there is no dilatation. In the second grade, there is urine up to the pelvic alyssal system, but still there is no dilatation. In the grade 3, there are mild dilatation of pelvic alyssal system and that fornicis.
No dilatation. Without dilatation, it will not go up. So
Yeah.
maybe minimal dilatation.
Mild to minimal dilatation.
Of the lower ureter up to the pelvis.
Third is dilatation up to the pelvic alyssal system, but the angles of that calycals is maintained. In the 4, there are some blunting, and in the 5, 4 is 4 is still blunting of the, not blunting, only that dilatation is there, and the 5 is gross dilatation, tortuous ureter, and there is disappearance of that loss of papillary impression, grade 5. Yeah, should I?
You can draw. Yeah. Is there a whiteboard marker? Nothing is there.
Can I drawing paper?
Yeah. Time. Marker, yeah.
Reflux into ureter.
Yeah, lower ureter. And in grade 2, it will be systemic margin. And in the grade 3, there will be some dilatation of ureter, and also these are dilated, but the cellular impressions are still preserved. And in grade 4, there is some blunting, but it is
Not blunting. In grade 4 there is clubbing. So
Clubbing, yeah.
it turns inside out.
But there are some angles.
But papillary impression is still preserved.
And in 5, it is all dilatation of ureter, tortuous ureter, and then almost
That's good. So at that stage, you have diagnosed grade 5 reflux on the left side. What would you do surgery or would you continue? If there is medical manual, what medical manual would you do?
In medical management, it is continuous antimicrobial prophylaxis,
How
which
long will you do
include
continuous microbial?
till the like spontaneous resolution of reflux or after surgery, if there is no reflux, and yeah.
Will it go on indefinitely for years?
Generally, reflux like spontaneous resolution take place if it is going to then up to 2 years of age, and after that, if it is not.
4 years.
Which study tells us that okay, you should give antimicrobial or not give?
Yeah,
Which study?
that is randomized intervention in the viewer.
What did reverse show? Just briefly, what was its finding?
So that was like primary outcome in that is antimicrobial prophylaxis. So primary outcome is decreased incidence of febrile UTI, and secondary was like development of renal scars or other complications or antimicrobial resistance. So it showed that with the antimicrobial therapy, the primary febrile UTI are reduced, but there is no change in incidence of development of renal scar or other secondary outcomes.
And it was also with increased development of
Resistance.
Two indications which makes you to give antibody prophylaxis in any risk you take. What things you give? Like any simple UTI you want to give or what?
No, not in simple UTI. If patient is having reflux, then we should give.
Reflux they will have, that's the primary disease.
Recurrent UTI.
That's what? All recurrent UTI you will give? Already one is febrile UTI.
Febrile UTI, yeah. Symptomatic febrile
Then
UTI.
another one where it
And after transplant.
other than genitourinary tract, what other things is very important? Pardon? Bowel dysfunction. Two main indications where
Antibiotic prophylaxis.
one kidney is non-functioning.
Yeah.
Grade 2 reflux is there in this lady.
Right sided,
Yes,
grade 2.
or 3, whatever. It's not grade 4 or 5. You want to operate or not?
At this age, I would like to operate because as there is left sided non-functioning kidney, and if it all.
Sex and grade 2 to 3 reflux. Whom to operate, whom not to operate.
In grade 2 to 3 reflux with bladder bowel dysfunction, then we should not operate. We should just go for.
Sex, male and female.
Acha, okay, sex.
Whom you want to operate, whom you don't want to operate.
In female, I would like to operate because there are less chances of spontaneous resolution in female. And female have more tendency for UTI, febrile UTI also in the course.
Not real.
That's
No, it will worsen during pregnancy. So in all the time in female reflux is there, we try to operate irrespective of the grade. In male, he may doesn't have any problem, he will just progress. Means he may just remain like that.
Supposing you are planning surgery, small child, what type of surgery do you prefer for this?
There are some endoscopic surgery also, though they are not having good outcomes in this form of that reimplantation. But considering the risk at the same time in the younger age, I would like to go first with the endoscopic. But at the same time, open is the
lower
best.
grade reflux endoscopic is quite good because what will the endoscopy achieve?
So ultimately that it increases the intravesical segment of the length.
The main important thing is that infections will come down.
Yes.
That's what you want to do. That's why you want. So endoscopy is simple to do. You can do it endoscopy. You don't need to open.
Yeah, open surgery.
So that's why you want to do an endoscopy. Reflux. That will be much better. I think. So do you think this surgery for reflux could have prevented this eventuality in this child? Supposing they diagnosed early, probably they had some problem. Why they diagnosed this, I don't know. We do not know what happened at that time. But putting PCN and not a proper treatment for reflux. But if they diagnosed reflux early, would the outcome have been different?
Sorry sir, what is the term?
Suppose you had diagnosed reflux at that age of 4 years for this child, first episode of pyelonephritis, and you had done the surgery and whatever. Would the outcome have been different?
So the febrile UTI episode may be reduced, but otherwise the secondary, as we have discussed, that renal development of renal scar doesn't change with the surgical treatment also. Only that febrile UTI only reduced.
So in course of time you can, but you can postpone
all
events. Probably the morbidity would have been much less had surgery been done with proper time. In most of these pediatric urology problems are not properly diagnosed. A lot of treatments are all down where they are messed up because they are not generally keeping up. The pediatric surgeons don't generally keep.
They keep operating, reimplant.
Very unfortunate.
They need to involve a pediatric nephrologist.
Should the nephrologists have been involved at the age of 4
Yes, sir. Definitely.
What additional benefits would have, apart from surgery and manage infections, what else would you have done for the child in order to go the eventual development?
Other complications of CKD like management like anemia, then growth and developmental like CKD, MBD, and apart from that like preparation eventually if required.
One more thing that you would definitely look for, which the surgeons will never look for.
Which will prevent the progression. It has been proven. Anemia, CKD, MBD, what is the other complication?
Cardiovascular. No, sir, not.
What complications do you expect in these type of diseases in children?
No, but
Which electron? Acidosis.
Acidosis. It is more.
Correction of metabolic disease.
And it's something very easy to treat. You just have to give them sort of that.
What are the indications for nephrectomy pre-transplant?
High grade vesico-ureter reflux with the history of recurrent urinary tract infection or pyelonephritis in this patient.
In all, if there is a history of a UTI, the patient has got dilated ureters and hypernephrosis, is it straight away go for nephrectomy?
If high grade VUR, then yes, before surgery.
Supposing now a urine culture is set, you want to do.
Yeah, to prevent like after transplant to prevent the recurrent infection from that reflux.
So what you can do and what is done by scientists, selective ureteric catheterization and cultures from there. And if they aren't, then you can leave them alone. If the selective ureteric catheterization some samples are sterile, you may not submit them to.
So during that cystoscopic procedure or from
cystoscopic.
Okay.
Any other indication? Nephrectomy.
If baby is very small, like that size, because in pediatric transplant, if there is smaller space, but it is not.
How do you think nephrectomy will solve the space here?
It won't.
No.
How much volume does the baby kidney occupy?
Anybody else?
Other indications.
Anybody else?
Any ADPKD, not all ADPKD, if it is having recurrent infection or cyst hemorrhage or any bleeding complication from that cystic disease, then only.
Otherwise, you can leave it alone.
Yeah.
Suppose a large kidney anchor.
Yeah, if it is like occupying till the pelvic region, then we should consider for unilateral nephrectomy. But it can be like.
Suppose you don't do an nephrectomy in ADPKD, what will happen to those kidneys after transplant?
What?
Will they continue to grow?
It is shrink, like it is said that after transplant that ADPKD kidney generally tend to shrink little, but there are no specific.
Generally the kidneys tend to reduce in size after transplant. Is there any other alternative? Suppose after transplant the kidney is creating problems. You don't want to do under surgery.
Then there are interventional procedure like selective embolization for bleeding complications. That embolization of that kidney for that, yeah. Yes.
What would be a medical nephrectomy? You can't do it post-transplant, of course.
That is you with the help of NSAIDs and like endomethacins or high dose of ACE inhibitor and
NSAID together.
Yes,
Why?
yes. Sorry, sir?
Why both together?
Because they are acting both and the glomerular efferent and efferent both arterioles.
So they make the glomeruli
completely blocked.
Who acts on afferent and who acts on efferent?
NSAIDs will actually ACE inhibitors act on both, but it is more preferential on the efferent, while NSAID will have more on the efferent.
Any other indication for nephrectomy?
Before transplant, that RCC, renal cell carcinoma in patient with FSGS or like Bill's tumor syndrome? Or
Suppose an RCC comes positive on your nephrectomy specimen. When can you do it?
if it yeah, that if it is localized or nothing, no extra renal, then we can go proceed for transplant. But exactly I don't know.
So yeah, people would do a PET scan today.
Yeah,
and look for activity.
extra.
Any other indication for that? Very specifically congenital nephropathy. Yeah, so intractable proteinuria or intractable hypertension.
And this patient had a lymphocytes, post-transplant or collection.
Yeah.
So what are the indications for drainage of collection after transplant?
If it is causing compression to the ureter, surrounding ureter, or if it is like hampering, decreasing the kidney function by the compression, that is one indication. And for diagnostic procedure also, like
diagnosis.
When do you want to obstruction?
Yeah.
When you want to drain something?
If it is large collection on the, there is associated with fever or something like infected collection.
So in this patient, they put a stent as well.
Actually, yeah. So she was told at that time her urine output was decreasing. So on the imaging, they found some collection which was like probably compressing the ureter also.
Could it have been a urine test?
It could be.
How would you distinguish?
With the help of serological test, like see that albumin of that collection and that TCDC and creatinine of urine.
Urea and
creatinine.
You want to check albumin.
So what all urea and creatinine do you need to distinguish?
Serum creatinine and at the same time from collection drain creatinine. And urine creatinine also. So to correlate between that.
All three should do
simultaneously at the same day.
So you are not doing anything. If there is a collection, how do you other modalities to identify it without putting a needle and collecting that collection? How you can say urine is leaking?
No, but imaging.
What imaging you want to do where you can identify that imaging urine?
Yeah, fluorescence might be the help of.
From my side, my viewers, summary you should improvise.
Yes, sir. Yes, sir.
It will be good to impress the examiner. Way of presenting the diagnosis also means you told CKD, transplant. Ideally in a transplant, you start with the transplant, live-related transplant, ABO compatible, fetal immunosuppression. Then you go for primary disease. Most probably what is your diagnosis. And in your history also you jumped here and there for the chronology, but better than the first fellow. But what I want to say is that you should go to a, in a way, you got 2 bladder surgeries. Once you say bladder surgery, you will know whether they have advised CIC or not, what type of bladder surgery.
So that was not there. There is no history. Yes, yes.
You will have a clear picture.
Yes, sir.
What most likely the surgery was done. And post-transplant, you just say triple, and then you go for the infection part. You have to tell me all the things. You told no hypertension, no diabetes, and prophylaxis. What prophylaxis you have given if you have?
So yeah, she was given after transplant the routine Septran plus okay sir. Yes, yes.
Infection you are putting, you should tell us.
Yes, sir.
Those things you should tell in addition to whatever the information.
Also, apart from that, one thing, your presentation should have elegance. So when you present something, it should be a smooth, clear, coherent presentation starting from one end to the other. But like you said, for this patient, like sir said, you should start with the transplant. So that is the primary.
Okay.
So we are coming to that, we are thinking this is going to be a case of Cath. Suddenly you come to transplant, the whole thing changes. So like saying that this patient had edema, this thing, that thing, and then after half an hour you say you have diabetes. So that changes the whole thing.
Primary
so you should have those things in the beginning. Only. But anyway, it was good.
Okay.
So a little bit of improvement and.
Thank you, sir.
Right.
Thank you,
Thank you. Thank you. We continue here. There's a schedule.
Good afternoon. I'm presenting a short case today. Name of the patient is Mr. Kabilan. He is a 10-year-old male who has studied till 4th standard, and the informant is mother, and the history is reliable. Chief complaints: patient has just been examined during a follow-up visit. History of presenting illness: the patient is a 10-year-old boy who has been recently diagnosed with hypertension 3 months ago, when he presented with complaints of bilateral knee pain, bilateral lower limb pain, and difficulty in walking for a duration of last 1 month, with history of poor growth in terms of both height and weight since the age of 5 years. During this phase, patient had no difficulty in passing urine, had a normal urine output. There was no history of recurrent fever or dysuria or pain while passing urine. The stream of maturation was normal, and there was no history of hematuria, no history of frothy urine or pedal edema or facial puffiness. There was no history of bony aches and no history of fractures or abdominal pain or behavioral abnormalities. There was no seizures or any history of carpopedal spasm, and the appetite was normal with no volume overload symptoms or uremic GI symptoms. Patient had not consumed any NSAID or native medication in the past, and the patient was told to have bilateral shrunken kidney with a high creatinine. Patient was then initiated on hemodialysis within the day of presentation and via a right IJV hemodialysis double lumen catheter, which was then changed to a perm catheter within 1 month. Patient is currently on maintenance hemodialysis, vintage being 3 months, residual urine output currently being 300 ml since the onset of dialysis, with an interdialytic weight gain of 0.5 kg and no significant intradialytic complications via the right perm cath. Past history: patient is found to have hypertension 3 months ago. Personal history is all normal. Birth history: the mother was healthy and it was a spontaneous conception, nil comorbids and an uneventful pregnancy with no prior history of abortions. Birth history: the baby was a full-term normal vaginal delivery and the baby cried immediately after birth. Birth weight was 2.5 kg and the baby passed urine within first 24 hours of birth. The vaccinations were administered as per schedule. Developmental history: patient had delayed developmental milestones in all aspects. Neck holding was at 10 months, sitting was at 1 year, walking without support was at 2 years, running at 3 years, talking at 4 years, and bladder control achieved at 8 years, with the dentition, however, first lower incisor at 11 months after birth. Family history: nothing significant. No, patient has got one younger sister, but normal and healthy. The parents are also healthy. No history of renal disease in the family. Treatment history: patient is on dialysis since the time of presentation. General examination: pulse was 100 beats per minute with regular rhythm and normal volume. Beep. Yes, sir.
What Dr. Swarnalata said about the first case. Here you've got a 10-year-old child.
Yes, sir.
Height and weight is mandatory.
Yes.
And one more step here, you'll have to tell us the sentence.
Yes, sir. Yes, sir. So
annual examination, anthropometry first,
yes, sir.
then vitals, and then others.
Right, sir. So anthropometric: the height of the child is 96 centimeter, which is less than the 5th centile. Weight is 14.9 kg, less than the 5th centile. Head circumference is 50 centimeter, which is normal. Upper segment is 52 centimeter, lower segment is 52 centimeter. Ratio of 1:1 maintained for the age. His mid-arm circumference is 16.5 centimeter, less than the 3rd centile, and mid-thigh is 25 centimeters.
Body surface area?
I'm not calculated that, sir.
Would you like to know it?
For dosing of some medications, then yes, sir.
Something else that you need to dose?
For dialysis, selecting the dialyzer.
Selecting the dialyzer, what should it be?
So 0.7 F4 dialyzer for pediatric of this age group usually.
What is an F4 dialyzer?
The dialyzer size of 0.7 will be the dialyzer size.
0.7 meters squared is the surface area.
Surface area.
F4 is equal to 0.7. Incidentally, you don't get F4 anymore. What you get is something called F4HPS. Each of those letters means something to us. What do they mean?
To go through that, sir. Not sure.
F, Fresenius polysulfone. So it tells you the material of which the dialyzer is.
Yes.
O tells
The
you
surface
the
area.
number tells you the surface area.
Surface
So you were right. And F4 is 0.7 square meter. HPS.
Not sure about that.
High performance steam sterilizer.
Okay, sir.
So every letter in the name of the dialyzer
Okay, sir.
carries some information.
Okay, sir.
The HPS versions have slightly higher surface area.
Higher surface areas and more higher ultrafiltration coefficient.
Okay, sir.
So your what? So you said F4. So just is pediatric equal to F4?
Based on the surface area
How much?
and
0.75 to 1 into surface area. So your dialyzer should never exceed the child's surface area.
yes, sir.
And it should be usually 0.75 to 0.8 into the surface area.
Okay, sir.
Tell me.
Yes, sir. Coming to the after anthropometric examination, vitals, pulse rate is 100 beats per minute, regular rhythm and normal volume with no delay. BP was 100 by 70 mm mercury and saturation 100%.
So again, blood pressure in a child, centiles. 100 by 70 in a child is not equal to 100 by 70 in an 18-year-old or a 20-year-old. So there are centiles charts, you can ask for them in the exam, which tell you for the child's height and age what should be the centile of blood pressure.
Okay, sir. Respiratory rate is 24 cycles per minute and patient was afebrile. On examination, patient had pallor. There was no icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. Head to toe examination. The fontanelles are closed. Patient had frontal bossing. There was a flat nose with a broad nasal bridge and a flat philtrum with dental caries. Patient has got 2 scars in the lower aspect of the right neck, probable HD catheter insertion scars, and also has a right IJV perm cath in situ. There was no sternal abnormality or tenderness, no rib abnormality or prominence of the costochondral region. There is a pot belly and the fingers are short with double malleolus. In the knee there is prominence of the medial epicondyle, and spine there is no kyphosis or scoliosis. Patient had a waddling gait and testis was not palpable in bilateral scrotum. Systemic examination, CVS and RS were within normal limits. Per abdomen examination was abdomen appeared slightly distended, it was soft and non-tender, there was no free fluid, no organomegaly and bowel sounds are heard. CNS examination, higher mental functions and cranial nerves were normal. In motor system, the tone was reduced in the proximal aspect of the upper limb and the lower limb. And upper limb and lower limb power, the proximal aspect was 4 by 5 and the distal was 5 by 5, both in upper limb and lower limb. Reflexes were normal and sensory system and cerebellum were normal on examination. So my diagnosis, syndromic diagnosis is a chronic kidney disease, CKD stage 5D, dialysis dependent or maintenance dialysis thrice weekly. Native kidney disease, probably I would like to keep my first diagnosis as Cath, because patient has had developmental milestones since the time of birth. There were issues and probable bilateral renal hypoplasia. My second diagnosis could be a vesico-ureteric reflux, a reflux nephropathy secondary to vesico-ureteric reflux, and with the possibility of some genetic disorders to be ruled out, like metabolic disorders like cystinosis. And the next would be renal osteodystrophy, anemia of chronic disease,
Renal osteodystrophy as a diagnosis.
or renal rickets,
CKD-MPD.
CKD-MPD, yes, CKD-MPD, anemia of chronic disease.
Features of rickets.
So features of rickets, like on first clinical examination.
No, diagnosis. CKD-MPD
With features of rickets, okay, sir. And anemia of chronic disease, hypertension, and probable failure to thrive.
So what features of rickets we will look for in the child? From head to toe.
Yes, sir. From head to toe, first we start off with the fontanelles. There is delayed closure of the fontanelles. There is craniotabes as soft skull bones. Then there can be delayed dentition, and there can be softness of the bones, especially in the upper limb. When it comes to upper limb, there can be a curved ulna and radius.
Craniotabes occurs at what age?
Parietal bone and frontal bone.
Craniotabes occurs at what age?
By 2 years, sir. By
6 months.
6 months.
Less than 6 months.
Less than 6
So
months.
that is craniotabes. What
Yes.
happens after that?
Bossing, frontal and parietal bone bossing can be there. Then delayed dentition and curved ulna and radius. There can be splaying of the wrist, widened wrist, and there can be rachitic rosary and Harrison sulcus. These are both in the ribs. Then there can be a PGN chest, pectus carinatus with tenderness. There can be a pot belly, and following that in knees, patient can develop either genu valgum or genu varum, or sometimes even a windswept deformity if it is in an older child. That is valgus deformity in one and varus in the other. And there can be widening of the ankles.
Okay, you missed one portion. So how do you divide the skeleton?
Upper segment, lower segment. Axial and appendicular skeleton.
Axial skeleton contains what else? You said about
Kyphosis and scoliosis when in the spine.
So you always think axial,
Yes.
appendicular. Kyphoscoliosis occurs early.
Yes, sir.
So these are all the changes. you
Upper limb,
expect.
anything else?
Short fingers.
May just say again what all you mentioned in the upper limb?
Upper limb, I think I said increased curvature of the ulna and radius.
Increased curvature.
Of the ulna and radius, and splaying of the wrists.
What is increased
Like
curvature?
the bones could be a little bent.
Bent. Anything else?
And splaying of the wrists, wrist widening.
Anything else on top? What is normal carrying angle?
14 degree.
14.
13.
Not that
Sure.
specific, yeah, but 15 to
Around.
25. Is it gender specific?
Yes, I think women have a higher carrying
They
angle.
have more carrying angle.
Yes, sir.
Okay. So now in rickets, what do you get now? Corresponding to the carrying angle, what do you get? Like you have genu varum, genu valgum. Similarly, you have cubitus
It's
varum
higher.
and cubitus valgum. Okay, where the carrying angle is either more or
Yes.
Important if you are an international test. No, that was the excuse, no? That was
Muralidharan, yeah, that's right. Yes.
Angle, carrying angle is
Carrying
so
angle.
he's not bending his arm when pulling,
Yes,
his
yes.
angle is like this.
So this child, you said, what is the current plan for the child?
So currently patient is on maintenance hemodialysis, and he has not registered for any
You
transplantation.
said several times perm cap. So preferable to say tunnel cuff.
Yeah, I'm always very particular. Never say
Okay.
perm cap. You know,
Okay.
it's always TCC,
Tunnel
tunneled cuffed catheter.
Okay.
Yeah?
Perm
But
cap is
everyone,
not
please, you
putting
know,
on
it's a
the
very
legs.
common habit.
Okay, sir.
So
Very
in
correct
this
point.
child,
Yes.
who's 96 centimeters in height and 14.9 kg, what sort of a tunnel cuff catheter do you use? What do you use in an adult?
Tenkoff catheter. Sorry, that normal. This is tunnel cuff catheter, but not sure about the sizes.
In an adult, what do you use? What do you use? 15, 19, 23. What is 19?
19 centimeters.
19 centimeters from where to where? Tip to cup. So that is used. So that's this length from the tip to the cup for which right IJV 23. And if you have more than 40 it has to be more than 45. So it has to reach above the renal veins in the IVC. What about the diameter of it? 12, 13, 14. I heard all three.
14.5 is the standard one, what is available. So now you have a child. How do you decide? For a child who is 15 kg, 11.5 will be too large. 8 is what is available. So you don't get, 10 and 9 are very difficult to obtain. So 8 French, 18 centimeters. And that 18 here is not tip to cuff, it is tip to hub. Why do you need less diameter?
Because the vessel caliber itself
So how much of the vessel caliber can you allow to be occupied by a catheter?
2/3 of it.
2/3 is too much. Less than 50%. 1/3 to 50%. Beyond that, you will have the wall of the vein getting sucked into the catheter if it's more than 50%. So which is why you choose shorter and less. So how much flow will you get from an 8 French catheter?
Around 150 to 200
150
ml.
to 200 is what you can. How much would you need for the dialysis?
200 at least, sir. For a
Why 200?
good, for a better clearance, at least 200 ml per minute.
How do you decide flow?
How do you decide flow?
Child, how do you decide blood flow? Dialysis blood. 8 to 10 ml per kg.
Okay. So he's 15 kg, 14.9. So 120 flow would be added, 120 to 150 would be adequate. So an 8 French catheter is fine for this. Dialyzer, they said. So what about the tubing? What size tubing do you use? How are they different? 125 is a huge one.
75.
So, and the difference in the tubing is the pump segment is identical. In the new pediatric tubings that are available, the pump segment is identical to the adult one. There's a reason for that. And the rest of the tubing is thin, so as to occupy less volume. And the venous transducer is built-in, connected. So once you've used it, you have to throw that tubing. You can't use it. What would you prefer, HD or CAPD?
Preferably CAPD.
Why?
Because CAPD has got a lot of other benefits, as in it preserves the residual renal volume, so residual renal function, and the patient can be more ambulatory, can attend his regular work.
Yeah, so my pediatric nephrology colleagues tell me that the most important thing is the child can go to school, which he cannot do. Suppose you are worried about growth, this child may have to wait for a transplant. What would you offer?
Recombinant growth hormone therapy.
Very expensive and difficult, So I'm talking when you're talking about dialysis, is there anything you can do to improve growth, or till a transplant is done, they're not doing it?
At least achieve efficient dialysis so that he has got a better quality of living.
On hemodialysis, will they grow? When you say efficient dialysis, what do you mean by that?
I mean that overall patient symptoms must be better, must not have any uremic GI symptoms, must have a good appetite, good nutrition.
When you target some particular urea clearance, what sort of a GFR are you giving that patient?
Of at least 40, I think.
40? Are you routinely giving hemodialysis, giving somebody
Pediatric,
40?
not sure. URR we try to achieve URR more than 65%.
Yeah, so what sort of GFR does that give you? There's something called standard KT/V in which you normalize your intermittent therapy down to as if it were a continuous therapy, which is what you need. Any idea what the KT/V of a normal kidney is? 27, roughly. 25 to 28 somewhere. So we get KT/Vs of 3.6. So we are woefully short of what a normal kidney is producing. So is there something in pediatrics which is done to try and improve growth? It's available now. What is the 3H study anyway? 3H. The lead author is of Indian origin. Heart's height hemodiafiltration. So hemodiafiltration, right from Fishbach studies where he showed something that looked too good to be true, that growth improved even more than transplant with hemodiafiltration. But the 3H study has confirmed that growth is better with hemodiafiltration than with any other modality. And cardiovascular, so heart's height hemodiafiltration. So they couldn't, for children don't die of cardiovascular disease like adults. But what they looked at was LV mass index. And the LV mass index was better in children who were put on HLH.
So what parameters will you, so treating rickets in this patient, how will you monitor the rickets?
Now that the child is on dialysis, will require monthly monitoring since he's also got anemia.
What all will you monitor?
So first is hemoglobin because he's got an anemia and he's on dialysis.
Hemoglobin
Monthly monitoring.
No, it's not just the
Yes, sir.
correction of rickets.
And iron, TIBC,
For
and
rickets
ferritin.
specifically.
We look for acidosis, and we look for other bone metabolic bone disorder parameters: calcium, phosphorus, IPTH, and alkaline phosphatase. And
What about X-rays? What do you see on the X-rays?
X-ray, I think annual monitoring of X-rays to look for improvement. Like if we are starting the patient on treatment for rickets, then every 3 monthly monitoring is
What will you see
required.
on the X-rays? You are doing X-rays, why do you want
A
to?
better healing of the bones
How
will
will
be
you see
seen.
for healing?
The epiphyseal plate will be, there is no widening of the epiphyseal plate, adequate mineralization.
What will you look for? What will you see in the, before you start treatment? What will you see on the X-ray? What features of rickets will you? What X-ray will you take to?
If the child is less than 2 years, then the upper limb wrist X-ray can be taken.
So wrist X-ray, what are you going to do?
So splaying of the wrist and a widened epiphyseal plate, all of this can be seen, and there can be cupping of the angles and cupping of the ulnar
now
margin.
you start treatment, what will you see?
There is a at the epiphyseal metaphyseal junction there will be a healing.
What is it seen as?
The line.
Yeah, the white line you see.
The white line.
That's facial compound. So that once you see the white line, it means that you are on the right track. So you will monitor all that. You will monitor the calcium, phosphorus, the anemia, the ALP, the PTH, and you will also monitor the bone.
Okay.
Suppose you are planning surgery to correct the abnormalities.
Yes.
Surgeon is willing to do any time.
Tibial osteotomy and all that.
Yeah, no. So when will you do?
I think 7 to 10 years.
So 7 to 10 years, anytime you can just do it.
Not sure, sir. In the presence of an underlying CKD and dialysis, I think first correction of all the metabolic parameters.
Transplant will take a long time.
And then.
So he is not planning to transplant right now.
What is the cause of CKD in children? ESRD in children?
So first would be CACUT, and then genetic disorders like and metabolic disorders, cystinosis, oxalosis.
Is there a second cause? Cystinosis?
Tubulointerstitial disease, tubular.
Part of CACUT, no?
As in acquired tubular diseases, sir. Tubular diseases can also cause like even cystinosis, and all of this can cause.
Cystinosis is a very rare disorder, no?
Rare disorder.
So first cause is CACUT is correct.
Yes.
What is the second?
Reflux nephropathy.
Reflux is CACUT. Reflux is again CACUT. Congenital nephrotic syndrome. Okay. So the various nephrotic syndrome. That is second cause. Good cause. What is the third? ARPKD. Okay. Anything else? Anything else in the recent studies? You know, I mean, it is unknown. What has now come up? What is there? AHUS. AHUS, atypical HUS is one of the important causes. Maybe third, fourth.
Time goes.
Time is over. Okay.
So you did a good presentation. Say I'm quite impressed with your presentation. It was good. And that is half the battle is won in the presentation. Once you do the presentation well, you'll have to try very hard to fail after that. So, that way you go. Okay.
Thank you, sir.
The Mahapati is not coming.
Not come on.
Supposed to. I'm not supposed to be.
Oh, but you stay for the time. Taraftar is also supposed to be here. He has come.
He has come, no?
He has come.
Who is supposed to
Taraftar has come. Yes, okay. Ask him to come up.
We are not supposed to be here. Who is the long
Achha, so he is here.
They told them we'll be there. They are not going too bad. They are okay.
Sir, good afternoon.
Yeah. Your name?
Sir, Krishna Umar.
Please
Sir,
keep
can you
quiet,
start?
right?
Sir, can I start?
Short case or long?
Sir, short case.
Yeah, okay. Please keep quiet. Don't listen.
Sir, my patient is Mrs. Vijay Mary, 39-year-old, and she is coming from Chennai, housewife, and studied up to 10th standard. Coming to the presenting complaints on and of period edema for the last 6 months. And history of presenting complaints. And her complaint started as on and of period edema for 6 months, which was not associated with gross hematuria or reduced output, urinary output, or fever or any other infection. And she was evaluated 3 months back as she had abdominal distension with generalized edema. And she was told to have protein leak in the urine and mild renal dysfunction. And at that time, she was also detected to have increased blood sugars and was started on oral anti-hypoglycemic agent. And she underwent a renal biopsy. Biopsy was uneventful. And post-biopsy, she was told to have, it is a mild disease, but needs steroids and long-term follow-up. And there was no history of any weight loss, anorexia, hemoptysis, melena, or bleeding BV, or any history of NSIDs or indigenous drugs. And there was no history of any recurrent UTI. And there was no symptoms of SLE or vasculitis. And after starting steroids and other drugs, actually her BP has improved and her actually renal function has become normalized. And there was no history of any hearing defects or visual defects. And coming to the past history, and he was written to be hypertensive for the last 2 years, which was evaluated at the time of headache. And at that time, BP was only 180 millimeter mercury, and she was started on amlodipine single day dose, and no other investigations were done. And she was under regular follow-up every 3 to 4 months, and her BP was controlled. And she is diabetic for 3 months on oral anti-hypoglycemic agents, no history of any other medical illness or history of any surgeries.
Hypoglycemic or anti-hypertensive?
She is actually diabetic for 3 months and started on oral anti-hypoglycemic agent. And personal history normal, and family history, actually both are actually parents are diabetic and hypertensive, and her elder actually brother is also hypertensive and diabetic. Coming to obstetric and menstrual history, and she is married, 2 children. In both pregnancies, actually she had hypertension near term, and both were LSES, but indication was obstetric indication, and the BP was controlled with a single drug, and post-delivery BP was not monitored. So coming to the actually summary from the history and presenting complaints. So my patient is a 13-year-old female with hypertension 2 years and diabetes 3 months. Now actually presented with edema of 6 months duration and mild renal dysfunction, and underwent a biopsy and started on steroids. Now with a normal renal function.
Can you summarize this briefly?
It's a 39-year-old female with hypertension of 2 years and diabetes of 3 months, with edema of 6 months, no symptoms of acute glomerulonephritis, with mild renal dysfunction, and underwent a renal biopsy, post-biopsy, now on steroids.
The diagnosis on?
My first diagnosis is actually adult onset nephrotic syndrome, and possibly focal segmental glomerular sclerosis or membranous nephropathy.
No, don't give the histological diagnosis, the clinical diagnosis. Nephrotic syndrome, anything else?
It's an adult onset nephrotic syndrome.
Anything else apart from nephrotic syndrome? Just complete the diagnosis.
Full diagnosis.
Don't give the histological diagnosis.
Adult onset nephrotic syndrome, with type 2 diabetes and hypertension.
No, with regard to nephrotic syndrome.
Nephrotic syndrome.
Nephrotic can be steroid sensitive, steroid dependent, steroid.
Sir, actually she was started steroids only 1 month back only.
Okay. Then in remission or?
She's actually started only 1 month back only. Now her urine albumin is 1+. It's only 4 weeks only now.
Yeah, but remember what he's saying, no, that after
She had,
syndrome should always tell whether it's
steroid
sensitive, resistant, dependent, whatever.
Okay, sir.
Or calcineurin dependent, resistant, that should come after.
Okay,
Don't
sir.
go into the histological diagnosis. No,
Okay,
that is not the idea of the case presentation. Okay.
Say on 1 month of steroids.
Yes.
1 month steroids.
Okay, 1 month steroid.
Then type 2 diabetes and hypertension.
Yes, type 2 diabetes and hypertension.
And the other thing on nephrotic syndrome that you should try to say is whether it is primary or secondary. From clinical point of view, these are the things you have to stress on. No? This is the problem. People go into the histological part. No? That is afterwards. So do you think it's primary or secondary?
It's a primary nephrotic syndrome.
You think it's a primary nephrotic
Yes,
syndrome? Say that. No? So
yes,
primary nephrotic.
Because for a secondary cause, she had no systemic symptoms, no history of recurrent UTI, no drug intake.
I was wondering about why did you bring recurrent UTI in your history? In a nephrotic, how would it be?
Stands out.
Sir, actually recurrent, it does not produce, only if there is a reflex nephropathy also, it's a secondary FSGS which does not present with a nephrotic syndrome.
39. So that's like
She's only 39.
Current,
Yes.
And why hypertension?
And she had hypertension in both her pregnancies, and her last childbirth was actually nearly 14 years back. So she should have hypertension that time itself. Then after that she was lost to follow, was not monitoring her BP. So hypertension should have continued.
Can't say that should have continued. What is the usual course of hypertension in pregnancy?
Pregnancy, the hypertension will disappear by actually 4 to 12 weeks, within 4 to 12 weeks.
So most hypertensive, most pregnancy induced hypertension does not last beyond 4 to 12 weeks.
Then could
If
be
they
a
have underlying disorders.
primary hypertension also, because she has a strong
We can
family.
assume that she had hypertension all these years.
No, but hypertension started before pregnancy.
No, sir, it was actually during pregnancy, it was in the last trimester.
Both pregnancies.
Yes, both pregnancies, yes.
What is gestational hypertension?
Because it started after 20 weeks of gestation.
No, what is gestational hypertension?
It is actually hypertension, it is actually detected by systolic BP of more than 140 or diastolic BP of more than actually 90 millimeter mercury after 20 weeks of gestation. So which is actually recorded on 2 occasions, actually 4 hours apart.
Anything else?
Anything else?
What are the other causes of hypertension in pregnancy that will help you extend the definition? How will you classify hypertension disorder?
What is the classical classification of hypertension in pregnancy?
It's a
What is
gestational hypertension and preeclampsia with severe features or secondary hypertension. Other secondary causes. It's chronic hypertension.
So your definition, preeclampsia definition is also almost same, no? What you said for gestation.
What is gestational hypertension?
Gestational hypertension is systolic BP more than 140 or diastolic
That
BP.
is a diagnosis of hypertension.
Diagnosis.
What is gestational hypertension?
It is hypertension occurring in pregnancy after 20 weeks of gestation. Means
Anything?
Without
It is first time encountered after 20 weeks without any proteinuria or edema. That would be gestational hypertension. if there is proteinuria.
Normally, when is it usually when is it seen? Is it after 20 weeks or is it later? Usually later without any proteinuria or any end organ damage. What else? What else? There's 2 points more. Sorry? There's no end organ damage. That is a basic thing. Otherwise it becomes preeclampsia, no? Yeah, there's no end organ damage. It resolves
After pregnancy. After delivery.
and there's one more point after that. There's no IUGR. What is the prognosis? Yes. They have more risk of development of hypertension later on. So that is the full description of gestational hypertension. Okay. Right. So, what was her hypertension as per all these definitions? Just clarify exactly because I'm not very clear.
It was a gestational hypertension only, and she was treated with only one drug, and it resolved after pregnancy in her actually first pregnancy, and there was no complications, and the reason for LSCS was obstetric indication.
Okay. What is the fundus now?
Fundus are actually I couldn't examine.
Examination has still not come.
No, he finished it.
No sir, examination I have to come.
No, he has not yet completed.
Sorry.
Okay. You cannot tell us your examination.
So coming to the general examination, patient conscious oriented, and she is well built and nourished, and she is obese, weight of 70 kilogram.
Drop the well built and so now I tell height.
Oh sir, its weight 70 kilogram and height is 158 and her BMI is 31.
She's actually obese.
She's obese.
She's obese. She's 31.
And there is no pallor, icterus, cyanosis, clubbing, lymphadenopathy or pylori.
I said earlier also, apart from height, weight, what else should you mention in BMI?
Fundus.
As part of nutrition. Part of nutrition. There should be a sequence. Actually, these people keep forgetting. Waist hip ratio is very important. Waist hip ratio must be included. What is a thin fat Indian?
So when the waist hip ratio is less than 85 centimeter. So when the waist hip ratio is less than 85 centimeter.
There is what is Y paradox. There were two people whose
And comes from his institute. So one Y is an Indian from his institute and another Y is from UK. And published in Lancet in 2005.
Both of them were on the cover of the Lancet.
The Lancet article, a very good article. You should all be aware of it. It describes the thin fat Indian. YY paradox. Lancet 2005, I think.
Yeah.
Lancet 2005.
The distribution of fat is
It is more in the
So these
hip region.
YYs both had the same BMI, but they had done their body fat estimation and the visceral fat estimation. It was much worse in the Indian.
The UK guy had 9% and the
23.
Indian had 22%.
Yeah, 20 plus. So Yagnik, C.S. Yagnik is an endocrinologist.
And John Yudkin was the British.
So proud of I try to know this. Right. So please always check the waist hip ratio is must. So I don't think you have done that.
No sir.
And it correlates with cardiovascular matter.
Yeah, that's why it's more important. BMI is rather non-specific. Okay, continue.
And there was no pallor, icterus, cyanosis, clubbing, lymphadenopathy or pylori. And her pulse was, it was 90 per minute regular. It was normal in volume and character. No radiofemoral or aerial delay. All peripheral pulses were equal. And BP
No, you
was,
missed
it
one
is.
point again. You missed one point.
Pardon?
In the pulse. I'm very particular about, and that's the problem, with this current BP machines also, because everything comes from the machine. In the pulse, what else should you mention? You mentioned everything.
It was 90 per minute. Normal volume and character.
Regular.
Yes.
Regular.
Yes. It was a radial pulse, right radial pulse. It was a right radial pulse.
Okay.
Then there was
No radiofemoral delay.
no radiofemoral or aerial delay, and all peripheral pulses were felt equally. Condition of the vessel wall normal.
Condition of vessel
wall
wall
normal.
must mention.
And blood pressure was 110 by actually 70 millimeter mercury in the right upper limb in the sitting position. And JBP was not elevated. Then breast and thyroid was normal. And fundus, sir, I couldn't examine. Sir, I was not having ophthalmoscope.
You didn't have a fundus.
Yes, sir.
But in a hypertensive patient, it's worthwhile to
Yes,
see
sir.
the fundus.
Yes, sir.
Urine?
See the fundus, sir.
Urine.
So urine analysis in the initial, at the onset of diagnosis, she had her albumin
On
3.
examination, no, the current urine.
Current urine, now it is urine albumin 1 plus and RBC 1 to 2.
RBC 1 to 2.
Yes.
You did microscopic also?
Yes, sir, urine microscopy.
You have done microscopic?
No, sir, no.
Then how do you know 1 to 2?
Actually, urine analysis I got from the report.
Actually, they provided you the report.
Yes.
Short case.
Okay.
Or they provided. Okay.
And at the onset,
You are doing it. How do you detect albumin?
actually we have, for albumin, we have albu sticks are there.
So what does it do?
So its colors have actually multiple colors, and we have to dip that albu stick into the urine, and we have to see, then after that we have to compare with the color, whether it is
What causes that color?
presence of albumin.
Phenol blue. And the colors go from to green.
After dipping, how long do you wait? When do you see?
2 minutes.
No.
2 minutes?
Not for albumin.
Two minutes is for what? For leukocyte esterase. Very good. For leukocyte esterase, it is 2 minutes. Yes. 30 seconds. 30 seconds.
Is there any other way of doing it?
Sir?
Checking albumin in the urine?
Any other?
And we have nephrometry. No, that is for actually lab test.
You are doing it.
Then we can do the heat and acetic.
Yeah, heat and
Yes, actually heat and acetic test. So that gives only protein.
Sulfosalicylic acid does what?
It also gives actually protein, heat and sulfosalicylic acid also.
So which protein the sulfosalicylic acid helps you to
All proteins. All proteins. Any protein in the urine.
If you get a heat test negative and you get a sulfosalicylic positive, or albu sticks negative and a sulfosalicylic positive, what does it mean?
It's actually tubular proteinuria. Yes, Benz-Jones. Okay.
So in heat and acetic acid, also roll of acetic acid.
Sir, pardon?
Why do you use acetic acid in the heat test? Heat test will give nice coagulate. Why do you want to add acetic acid?
Boil an egg, protein coagulates. So you go and heat test the protein will coagulate.
Then why do you want to add acetic acid?
If we want to remove any turbidity or to make it
Remove turbidity. You want to see the turbidity. What turbidity do you want to remove?
actually phosphate.
Phosphates. Yeah. Phosphates can. Phosphates will get dissolved in
Acetic acid.
acid urea.
Acidic urea.
So now that you have diagnosed nephrotic syndrome and done a biopsy, what do you expect on the biopsy? You thought it's the primary nephrotic syndrome.
Yes, sir. So
examination is a finding?
Examinations are actually apex
Positive
beat could not be located. She's
Positive
obese.
finding.
No, sir. Only she had actually BMI actually 31.4.
Obesity.
Obesity.
Edema?
Now there is no edema.
The final diagnosis, is there any difference after your examination?
No, sir. With this, no, sir, no.
So what are the common causes of nephrotic syndrome in adults?
In adult, it could be actually FSGS or membranous nephropathy. And there can be actually MCD also. Yes.
So anything else can
And other glomerular disease can also present with nephrotic syndrome like MBGN or this IgA, and this in actually SLE also.
If suppose this is showing primarily a minimal chain type of appearance with IgA deficiency,
it could be an this IgA with MCD overlap.
okay. So because there are, so why do you say it's not an IgA nephropathy in that case?
And there are actually less than 5% of this IgA can actually present as an MCD. So there actually IF will show only this IgA deposition in the mesangium, and there actually we have to treat with steroids alone.
Yeah, but why do you say it's not an IgA nephropathy in that case?
IgA will have this actually segmental sclerosis or mesangial expansion, or this
Maybe we can
4K if
cellularity or this thing is not there, you can see primary product, but even then it can occur something. Even little bit of mesangial expansion can occur even in primary product. It's not possible to distinguish both of them. So IgA with NC-like presentation, how will you treat that?
What is it
treatment
called?
is,
What is the correct scientific name for that?
sir, pardon?
IgA with nephrotic syndrome. What is it called? You know, it gives the pathophysiology also. Yeah, so IgA with podocytopathy. You know, that's how KDIGO has described it. So
Even lupus with podocytopathy.
Lupus with podocytopathy.
IgA with podocytopathy will be actually treated like an MCD. In an,
Is the prognosis similar to that of IgA nephropathy or similar to that of a clinical stage?
and similar, here prognosis similar to MCD.
Okay.
MCD.
Supposing this biopsy is showing large nodules
Yes,
in the glomeruli, PAs negative nodules.
As negative
Deposits.
amyloidosis
So you think
by actually Congo red. So there will be apple green by reference.
okay, so you have done amyloid, so what else you look for in amyloid? It is an amyloid deposit.
And we'll do an IF and we'll look for this kappa or lambda restriction.
Okay.
Then we'll do the serum electrophoresis or immunofixation with the free light chain assay.
Suppose how will you distinguish between primary amyloid and secondary amyloid on biopsy?
What happens with A amyloid becomes negative. The staining becomes negative after K-MNO4 treatment. And AL, today of course,
But today what you do? You don't do anything.
you don't do.
Yeah. That was 30 years back.
30 years
What is done now? Yeah, so AA, you know the AA, I see.
And of course, if you go to, there are places which do laser micro
Fair enough.
dissection and LCMS on the flip to find out which protein.
I think your time is up.
Okay, thanks. Sir.
So you must improve your presentation skills.
Okay, sir.
You must be more smoother and clear presentation.
Okay, sir.
You present everything, but you should put it in a much more elegant manner.
And
Okay, sir. Okay, sir. Thanks, sir.
fundoscopy mandatory in a nephro case.
Because once there was an examiner, like student said, I didn't see because I didn't bring the fundus. So he said, you bring the fundus for the next examination.
No, we have to carry in our pockets, you know. Heinz, that small one, I still have it.
I still have mine.
I still have mine. We used to carry it along with the pen. So please carry your own.
In my exam, I got an aortoarthritis who had eyesight. So because I picked that, I got some extra marks. So fundus will help you all this.
Yeah. Okay.
Good idea.
All right.
Good afternoon, teachers and colleagues. My name is Madhav. I'll be presenting long case 6. So I'd like to present the history of Mrs. Menaka. She's a 25-year-old female. She's a homemaker. She studied up to BA Tamil and she's from Chennai. The history was given by the patient and it was interpreted with a translator, and it took the history yesterday evening. So, chief complaints, the patient was referred to the nephrology unit of KMC hospital with complaints of decreased urine output, pedal edema, and delayed renal function tests noted about 7 days after delivery, which was on 21st of May 2023. History of presenting illness. I would like to date my history back to September 2022. The patient presented to her local obstetrician at around 40 days of amenorrhea. A urine pregnancy test was done and pregnancy was confirmed, and this is her first pregnancy. A dating scan was not done and she was started on folate supplementation. She did not have any excessive vomiting, fever, rash or other drug intake in the first trimester. She underwent her first scan at around 2 months, and at that point of time she was incidentally they incidentally picked up some bleeding around the placenta. At that point of time, her clinical examination was told to be normal and she says her blood pressure was normal. During her follow-up, in the next month, she was told that her blood pressure was high. It was found to be around 140/90. She was again asymptomatic and did not complain of headache, blurring vision, epigastric pain, pedal edema, decreased urine output, and there was no other hematuria, nocturia. Her creatinine was checked and it was told to be 0.5. And a urine analysis was done, which she remembers having no proteinuria. An echocardiogram was done and it was told to be normal. A thyroid function test was also done and her TSH was told to be higher and she was started on thyroxine. Her sugars were normal at this visit. She was started on labetalol 100 mg BD and her blood pressure was subsequently normal with blood pressures of less than 120/80. She continued her regular follow-up with her obstetrician, and in the second trimester, she started appreciating quickening at around 20 weeks. She was on iron and calcium supplementation. She was not on aspirin as per her memory, and she underwent a GTT, which is told to be normal, and she also underwent TT vaccination, which is normal. During her second trimester as well, her blood pressure was well controlled. She did not have edema. A repeat urine analysis or a creatinine was not checked. And she used to undergo repeat monthly scans in view of the prior finding, and the scans were told to be normal. In the third trimester as well, she was appreciating her fetal movement well and her growth scans were normal. And clinically also she was asymptomatic with blood pressures also normal. At 37 weeks, she was induced in view of prior hypertension. However, in view of failed induction and in view of fetal distress, she underwent a cesarean section on 21st of May 2023. She was not aware of any hypotension or excessive bleeding during the procedure, and the procedure was uneventful according to her. A girl child with a birth weight of 2.9 kgs, healthy and cried at birth. Post-operatively, she reported one episode of fever. The temperature she did not remember. There were no chills or rigors, and it settled after one dose of paracetamol. At that time, she denied dysuria, frequency, hematuria. She did have a Foley's in situ. There was no foul-smelling lochia. There was no breast tenderness, swelling, or redness. There was no cough, dyspnea, and the wound was told to be clean, and she was started on IV antibiotics. She was also told that post-operatively her hemoglobin was on a reducing trend, and by around post-op day 5-6, her hemoglobin had reduced around 7 from 10, which was there previously. There was no excessive bleeding and other sources of blood loss according to her history, and they had done a scan of her abdomen, which was told to be normal according to her. 2 PRBCs were transfused. Meanwhile, during the same time, they also noticed that there was a gradual reduction in the urine output to about 500 ml per day, and she started developing pedal edema, which was up to the knee. There was no, she denied any abdominal distension.
Can I interrupt you? Up till now, she never had pedal edema?
No, sir. So she denied abdominal distension, periorbital puffiness. There was no cough, PND, orthopnea, no associated gross hematuria. There was no fever, sore throat. There were no rashes. There was no jaundice, abdominal pain, and no loose stools. She was told that her creatinine was also elevated at this point of time, and her creatinine was detected to be 2. And this is why she was referred to KMCH. And when she was shifted to KMCH, there was one BP recording of 160/90 And apart from this BP recording, all her subsequent BP recordings and previous BP recordings were normal, according to her. So she was started on amlodipine, and subsequently the blood pressure is less than 130/80. She was also, a urine analysis was also done, which showed proteinuria, which was present, which was not quantified, and an ultrasound was also done, which was normal. Over the next 3-4 days, her creatinine increased, and she was told that she required dialysis because her creatinine had increased from 4.5 with decreasing urine output. Creatinine had increased to 4.5 from around 2 and decreasing urine output. So she, right IJ-SG catheter was inserted, and she underwent 1 session of dialysis. Following the dialysis, she tolerated the dialysis well, and she was also advised a biopsy following the dialysis in view of the renal dysfunction. So she underwent a biopsy, and there was no transfusion of blood products prior to the biopsy, and she tolerated the biopsy well. She underwent another session of dialysis after the biopsy. Following the biopsy report, she was given some injections which she did not know, and was advised plasmapheresis. She has currently undergone 3 sessions of plasmapheresis, and she has tolerated them well except for 1 episode wherein she had generalized itching. She did not have any preceding joint pain, rash, arthralgia, photosensitivity or alopecia, and she's never, this was her first pregnancy with no prior abortions and no DVT. And following the plasmapheresis, her urine output has improved, and it has improved from less than 500 ml to about 1200 to 1500 ml. Her creatinine, she reports it to be stable around 3.5, and her last hemodialysis was on the 4th of this month, that is almost 5 days back. Her hemoglobin and platelet have also stabilized. Her hemoglobin and LFTs are normal. So that would be the history of presenting illness. Past history, she's never had any diabetes, hypertension, no prior renal disease, no tuberculosis, no prior surgeries or accidents. Family history, her brother has been found to have renal calculi, but apart from that there's no diabetes or hypertension in her family according to the best of her knowledge. She was not sure about preeclampsia in her mother. And personal history, she's on a mixed diet with normal bowel and bladder. Her menstrual cycles previously were regular for about 30 days, and she did not have any menorrhagia or oligomenorrhea. So summarizing, here's a 25-year-old lady, para 1 living 1, detected to have threatened abortion at around 2 months, detected to have hypertension at around 12 weeks with normal creatinine and no proteinuria. Started on levotiol with good blood pressure control subsequently, and subsequently an uneventful pregnancy. Underwent emergency LSCS following failed induction in view of fetal indications at 37 weeks. Post-operatively, she developed 1 episode of fever with no localizing symptoms, and subsequently was noted to have anemia, oliguria, edema, hypertension and renal dysfunction, requiring dialysis, a total of 2 sessions which she has undergone. She has also undergone a biopsy and some additional tests, and started on possibly steroids and 3 sessions of plasmapheresis with stabilization of her creatinine and CBC with improving urine output. So diagnosis at the end of the history. So para 1 living 1, post-op day 19 following emergency LSCS, with chronic hypertension, with pregnancy, acute kidney injury. I would like to offer a different, I would like to put TMA as my first diagnosis. Severe preeclampsia or HELP superimposed on chronic hypertension would be a differential, but because she has undergone plasmapheresis, I would not put this.
Just give the differential. That's okay. Discuss it.
You want to say postpartum HUS?
Yeah, postpartum TMA, HUS, more like HUS.
With the background of?
Acute nephritic syndrome is also possible. She has had like an IRGN.
No, syndromic diagnosis was what?
AKI. AKI. Pregnancy related AKI. Postpartum AKI.
And your differential diagnosis you said was thrombotic microangiopathy?
Severe preeclampsia, help.
And you also wanted to keep IRGN. That's what you said?
Yes, sir. Yes. But much lower down.
Which are the TMAs of pregnancy?
HOS and TTP, atypical HOS and TTP. Help.
All three have been.
Help.
So are they different or same? Or part of a similar syndrome? So what is it?
They're different, I mean,
yeah.
But so for example, TTP would have more of reduction in the ADAM13 level or an antibody.
We don't know that from the history.
We do not know that from the history, but she does not have neurological symptoms, so it's unlikely to be TTP. It's more towards atypical HOS.
Is there anything, if you have to clinically from the history and findings, distinguish between these three conditions? Yeah, after that, of course, the diagnosis is made on investigation, confirmed on investigation. But these three syndromes, all are TMAs. History and examination can be distinguished or attempt to distinguish.
Yes, sir. So in between help, help is the commonest. Help would have more of elevation of liver enzymes. Thrombocytopenia wouldn't be as severe as in TTP or HOS for that matter.
But those are all investigations.
Investigations, yes. Abdominal pain would be more in help. Abdominal pain.
Time of presentation.
Time of presentation, yeah. So time of presentation, help can present somewhere between the second trimester to around 2 weeks postpartum, typically. While
very unlikely for it to present first time postpartum.
Yeah, unlikely for it to present postpartum.
So I think here started as postpartum.
Yes, sir. And help would typically improve after delivery.
Exactly.
And TTP would present typically in the third trimester, whereas HOS would typically present from third trimester towards postpartum. More of postpartum because, yeah, more of postpartum.
So that's one, the time of presentation is one distinguishing feature. Anything else?
Presence of hemolysis, jaundice.
The severity of the
severity of renal failure is more in the HOS.
Dialysis dependent renal failure is much more common with
HOS.
Very unlikely with TTP, which is more of a hematological come neurological condition, and with help possible, but again uncommon. This patient has received not just dialysis, but
Plasmapheresis.
it was severe enough to need, somebody decided to do a biopsy, and then based on that data. While I don't want to hang my diagnosis on something that someone has done, except for the fact that this patient has improved after that intervention. So again, pushing to both the time course and the severity of renal failure and the recovery with PLEX seems to suggest HUS. Anything else?
It's like a primary, second. Now HUS they divide in a different way. So where you pick this?
This would be a secondary HOS. So pregnancy related is secondary. So
As of just now, yes, but that is changing. There is a huge controversy, and based on the three large studies which have been published, one from France, one from Spain, and one which is a mix of the French, the UK and the Italian group together. That's the largest study, 83 cases. They are saying that most of these patients had what? Which abnormality did they find?
CFH, 20% in pregnancy, complement related deficiency.
So based on that, it maybe it's being believed today that pregnancy is a trigger
as a secondary event, second hit or a trigger for a patient who may be predisposed, and therefore in the near future it may go into the group of complement mediated HU.
About 20% have CFH mutation and about 15% have CF5 mutation.
Basically, for anything, you have to do all the panel of tests.
Considering this as HUS, this patient had, what was the cause for hypertension? You mentioned it as chronic hypertension. If it was chronic hypertension, why this patient had chronic hypertension? Is it chronic hypertension?
The pregnancy, the hypertension was detected before 20 weeks of gestation. So it would be chronic hypertension.
Before 20 weeks means not related to, you can say it's not preeclampsia, but
And there were no, they had not worked up endocrine causes, but there were no other causes that were found except for.
What you are suggesting is it is unrelated to the kidney problem. Is that what you are saying, or is it related? So this patient was diagnosed with two different problems during pregnancy. One is postpartum HUS and one is chronic hypertension in the first trimester.
So in the first trimester, when a creatinine was checked, it was 0.5 and there was no proteinuria.
That's all okay.
So it's unlikely to be related to the HUS.
No, but HUS was there in first trimester.
She is getting a hypertension in 12.
Yes, sir.
What are the possibilities? When on early PIH, it may be just a matter, there was no protein. So
No.
which patients they get early hypertension?
This was a first gestation. So typically risk factors would be first gestation or multiple pregnancies, IVF induction, or
Pre-existing disease, CKD and heredity for mole
heredity from molar.
But what you are saying is this is chronic disease. That's what you are saying. This is not related to the pregnancy. That's what you are saying, right? Yeah. What in this 25-year-old lady, she was found to have hypertension at 12 weeks of gestation. What do you think is the reason? You are saying it is not related to the HUS, it is not related to the pregnancy also. It is not gestational hypertension. So then why she has hypertension? She required treatment through the pregnancy.
Yeah, that needs to be investigated as to why she had. But secondary causes like endocrine causes, hypothyroidism, Cushing's, Cons. There was no proteinuria, no hematuria, normal creatinine before. There was no gross hematuria.
microscopic hematuria she may have. So how you define I want? You will leave apart your plasmapheresis. I have detected somebody hypertensive, and then on the day you are very specific that BP was not high. I will tell BP was 200. So on that day when she came, she had a malignant hypertension. I will take. You want to link or you don't want to link? See, when you get two diseases, either you have to link. When we can't link, we have to separate it. Correct. So I wanted to.
So this HUS typically is in.
I'm trying to correlate whether it's possible. Your opinion, I want to know. How you plus or minus. You understood my argument. Somebody young hypertensive, she presented with PMA postpartum, okay, her BP was 220 on that day.
So hypertension and
it's a malignant
hypertension
everything
with
fits.
secondary.
For me, everything fits except your plasmapheresis and improvement. That we rarely do for a malignant hypertension based on the biopsy fact, right? So how do you define?
She never had any headache, blurring of vision. Her blood pressure recordings were always told to be normal previously, and on examination findings obviously, but
160/90.
one reading of 160/90. It's high.
That was enough for amlodipine to be added on.
Yes.
So she was on 2 antihypertensive.
No, only one antihypertensive. Labetalol was stopped and only amlodipine was started.
It's actually IgA can have hypertension and TMA. In most of the biopsies you see hypertension mediated TMA. You see in the biopsy.
mean, prior blood pressures being normal and no proteinuria, no creatinine, and suddenly developing doesn't fit in.
What is the normal course of IgA?
IgA may have remission, it may have worsening, but I mean, it's not effect. Okay.
Let him examine.
Yeah, go to the
examination.
So, on examination, the patient was conscious, oriented to time, place, and person. Pallor was noted. There was no ictus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Pulse was 78 per minute, regular, normal volume character. Peripheral pulses were present. Blood pressure was 124/76 on the right arm, supine position. Respiratory rate was 16. Her height was 158 centimeter, weight was 52 kgs. A right IJ-HG catheter was noted on her. Her JVP was not elevated, and head-to-toe examination did not reveal any skin rashes, joint swelling, alopecia. Per abdomen.
What about blood pressure in the other limb?
It was normal, sir.
Same. It was the same, normal, or?
It was same, sir. Same. There was no differences in blood pressure. Per abdomen, on inspection, the wound appeared healthy, and otherwise there was no abdominal distension. On palpation, there was no hepatosplenomegaly that was noted, and the uterus was just above the pubic symphysis, and it was firm. On percussion, there was no ascites, free fluid, and bowel sounds were normal. CVS inspection apex was at the 5th intercostal space, and it was confirmed by palpation. There were no thrills or bruits. There was S1, S2 that was heard. There was no S4, S3 or S4, and there were no murmurs in the cardiovascular examination. Respiratory system examination was predominantly normal, and CNS fundus, higher mental functions are normal. Fundoscopy was normal. There was no changes of hypertensive. Normal, sir. There was no hypertensive retinopathy. Motor system was normal. Sensory reflexes were normal. It's predominantly normal.
Anything in the neck you would look for in this patient? Patient started on L-troxin, no?
Yeah.
There was no thyroid swelling.
So your diagnosis now, any changes or remain the same?
I think they remain the same as of now.
What are the things you explored?
I wanted to see if the hypertension was chronic or not. I mean, whether there was end organ damage of hypertension or not, which was not there. And
also some of the causes of hypertension.
Yes, sir.
Also
was not there.
So osteoarthritis or something in a young lady. So you couldn't find any evidence of that.
How would you investigate this?
I would like to do a CBC with a peripheral smear to look for schistocytes and the percentage of schistocytes, and
What percentage is significant?
more than 10% would typically be.
1%.
One.
More than 1%.
And I would also like to look at the PT-INR and APTT and the liver function tests, as well as creatinine, electrolytes, and urine analysis. I would also like to look at the complement levels. Complement C3 I would like to look at, and I would also like to
C3 alone, would it help?
no, I would like to perform C3, C4, AH50, CH50, and genetic analysis.
What
also.
happens to C3 in pregnancy?
It's lower.
No, goes up.
Pregnancy is the only
Uh-huh.
one of the
Pregnancy is
few
high.
conditions where C3 and C4 are elevated. So a low C3 in a postpartum therefore is very significant.
The only other condition which I know is infective endocarditis. Probably goes up, but if infective endocarditis is associated with renal disease, then it goes down.
Can you propose one diagnosis which will explain everything in this patient? including
Put one umbrella he wants.
One diagnosis.
Atypical HUS.
But what about hypertension in first trimester? There is some threatened abortion.
Apla syndrome.
Would you explain the other things also? Apla primary or secondary?
It could be lupus associated or it could be primary also.
Lupus is a female. Yeah,
Lupus.
So you talked about complement, but is there any way of distinguishing on now, because it's come to investigation? If we start doing all the complement level, we are assuming that this is a complement mediated HUS. So before that, and assuming of course that we saw this patient before the plasma exchange was done.
Could you repeat the question?
What investigations now would help distinguish among the 3 TMAs, assuming, as I said, that this was done before the plasma exchange?
Adams TS13 level and Adams 13 inhibitor level, and a genetic panel would to look for meeting AH50, CH50. So C3 nephritic factor.
Is there any C3 nephritic factor?
I mean, AH50, CH50 would
Is there
help
any
us.
test for preeclampsia help?
SFLT is to placental growth factor ratio.
So that is also, because very often in the immediate postpartum, it's extremely difficult to distinguish between a health which is going to improve in the next 2-3 days and an HUS which is going to get worse. And at that point of time, the genetic test is going to take a very long time to come. So the decision is always do plasma exchange or not do plasma exchange. So if the SFLT placental growth factor ratio is suggesting help, one can wait. If you don't have it available, then it's most of the time we will say, okay, let's go ahead and do plasma exchange without waiting. Any reason why you would very early go for plasma exchange if you're suspecting HUS? As I said, the dilemma is often there. You really can't distinguish. Platelets are about 1 lakh. Hemoglobin has fallen, but then this patient has been through a cesarean. The LDH is about 900. And the patient is dialysis dependent. So, what's the reason why you really, if you are suspecting an HUS, you must go ahead early?
There's going to be significant TMA, and it can even precipitate an acute cortical necrosis.
Cortical necrosis. There is a paper from PGH Chandigarh in which they have shown that 75% of their cortical necrosis had an underlying TMA, which is huge. Typical age. And then we went and did, and that's published in Nephrology Carlton, that 80% of our postpartum HUS had complement gene abnormalities. So that's, as I said, when this is all put together someday by the authorities, the European papers, our own paper and others, there's one I think from Pakistan or Bangladesh, which is again showing a large number. They will put pregnancy-related HUS into complement mediated disorders.
I think there was another publication which I had seen sometimes back, long time back. Actually, in fact, about 30% of pregnancy-related complement and all was very, very effective.
And because cortical necrosis, there's also a paper which is from Oklahoma TTP HUS registry, in which they said if you start in the first week, the recovery is much better and the number of plasmapheresis sessions required is on average 7. If you wait beyond 7 days, then the average number of sessions required was 34 and the recovery was only about 50%. So starting early when there is this doubt is what?
Once there is established
Disease, yeah. Then it becomes very difficult. What is your prescription for plasma exchange?
1 to 2 plasma volumes, at least 7 exchanges in 14 days. Probably daily.
For first, maybe first
5 to 7 days.
How will you calculate the plasma volume in this patient, for example?
40 ml per kg would be 1 plasma volume, but
hemoglobin,
hematocrit, yeah.
Pregnancy, there is a volume expansion.
Yes. I don't quite remember the hematocrit formula by heart.
0.5
This
give
patient.
6.5 into 18 kg into 1 minus hematocrit.
So what do you expect in the biopsy? And what will, at least, what part of the DNA will make you happy that she will recover? You can prognosticate. What do you expect in DNA biopsy?
Glomerulomegaly will be there, and
Four broad, Rennie Habib many years ago gave 4 findings in TMA, 4 different possibilities. One of them, as I said, makes you very happy, the other is a disaster. The other end of the spectrum is the disaster.
fibrin thrombi and
Which type of thrombi? Where is the thrombi location?
In which part, if it is there, you can wash it out.
If you have that other thing you have it as a poor prognosis is cortical necrosis will be very.
The one end of the spectrum is cortical necrosis. Those are not going to recover completely. Some of them don't recover at all.
Other is already stated. Glomerular. Another.
arteriolar.
So Rennie Habib said ATN, glomerular TMA, arteriolar TMA, cortical necrosis. If you get an ATN or a glomerular TMA, you should be happy.
Prognosis is better.
If you get a cortical necrosis, the prognosis is very bad.
Non-PTL, they will have persistent of hypertension, difficult to control. They also may have, because it's a patchy area, so patchy cortical disease. Also,
Could you?
arteriolar, they will have more manifestation.
More hypertension. One more thing in your prescription of plasma exchange is what replacement.
What replacement you want?
Plasma replacement.
Volume for volume.
Volume for volume plasma.
This patient you mentioned, one of the sessions she had some itching or something. Why do you think she had that?
Anaphylactic reaction to.
Itching is not
I mean, allergic reaction to the FFP.
Transfusion reaction.
Transfusion.
Okay, what are the other common complications during plasma exchange?
Hypocalcemia.
Most common is
most
hypotension.
Why?
Inadequate volume replacement.
So the removal and replacement, if the rate is not matching.
It's more common with which method?
Saline replacement or centrifugal membrane. It's more common in the membrane one than centrifugal.
What are
the worst? What is the worst complication you can get? Which then you just have to stop plasma exchange and give up. We run into it and then we're really on the horns of a
Anaphylactic shock.
Trally. Trally is totally unpredictable. You can have done 2 sessions of plasma exchange absolutely smoothly, and in the third one, the 20th bag of plasma, you will get a trally. And then once you've had a trally, you can no longer give plasma exchange.
What are the advantages of filtration technique over centrifugation? Is there any difference?
We can use the same machine as the dialysis machine.
No, okay, all right. Anything else? Any complication which is less common in
hypocalcemia is less common.
Okay. Any
Whether you can use double filtration?
No. I'm not sure, sir, but I think no.
Any condition where you will not do filtration and will do centrifugation? Where because it will not work? Or is it equally good in all conditions?
Not sure.
Pneumococcal induced, is there any difference?
IgM, when you want to know IgM.
Pneumococcal induced TMA, is there any difference in the pheresis?
Neuramin.
What happen if you do plasma? If you use plasma, what will happen? You get hemolysis.
You convert your non-immune, autoimmune to an autoimmune.
If you have a child, which one will you prefer? Centrifugation or plasma filter?
Centrifugation.
What is the reason?
The vein the blood flow that you need is slower in centrifugation and use a smaller bore needle.
Do you have a continuous blood flow in centrifugation? Have you seen it being
I've
done?
seen it, but
so the aliquot, it takes an aliquot, right? So that volume can be very small, as little as 50 ml. So that will be better tolerated by. Otherwise, the extracorporeal volume is much higher in.
What genetic tests, supposing now you said genetic, so what genetic tests would you?
complement factor H, CFH, CFI, CFB, MCP, and
Okay, all of these are done by what? No?
Not too sure.
Folate. No, yeah. So next generation sequencing. But what the guidelines recommend is you are supposed to order both a copy number variant by MLPA as well as a next generation sequencing. Why?
The larger deletions are not picked up
Picked
by
up
the
by NGS. So NGS does not pick up large deletions and rearrangements. It picks up the small ones, and copy number variation picks up the large one. So I like one of the analogies that somebody gave for that. You've lost a forest and you're trying to look for a missing tree. That's the difference. If you try to look with an NGS for a large deletion or a rearrangement.
How would you treat if this was a different manifestation of a complement deficiency, and so what are the other treatments which are available, or it might become
Eculizumab,
One is
C5 inhibitor.
eculizumab. Anything else? Other complement.
If Tegopan is no longer is not yet available.
C5A inhibitor.
It's under track.
C5A inhibitors.
Avacopan.
Avacopan.
And Covasin also is under track.
There are some
Biosimilars are also available.
One?
Biosimilar.
Biosimilar eculizumab. What if you are going to use eculizumab? Because going by guidelines, it's the treatment of choice. Plasma exchange is not. We don't have it, so we do the next step. What are the precautions you?
Meningococcal vaccination.
Yeah. And how long before?
I think 2 weeks before.
2 weeks.
You should, ideally. The
Ideally.
reason is, but sometimes, you don't have time. That's the problem with these.
Like this,
these,
you don't have time to wait.
You don't have time.
So then what do you do?
Antibiotic prophylaxis.
Antibiotic prophylaxis, penicillin prophylaxis.
And that is also not available. You can't get penicillin.
Yeah, it's not easy to get.
Not easy.
Not easily.
Lipo benzathine is not available.
Not easy. So,
Next case.
huh?
Next case.
Yeah. Okay.
Thank you.
Yes. The 21-year-old lady who presented to the emergency with quadriparesis, for which neurology consult was taken, and organic brain disease was ruled out. The ABG showed, you were called to the ER because the ABG showed a pH of 7.5, bicarbonate of 33, and a potassium of 2.1. She was started on IV KCl infusion for quadriparesis, and nephrology admitted her.
What do you want to ask Dr. Rajiv? Any additional information?
This is it on exam? Sir, it looks more of what we say. Is it periodic quadriparesis? Any recurrence? It is.
She has had similar
Multiple episodes. Is there be any diurnal variations? It looks more of hypokalemic periodic paralysis.
Yeah, but why would he have alkalosis?
What does the ABG shows?
7.5 by
And does she improve on
After
But
treating with
why
KCL.
would hypokalemic paralysis, periodic paralysis will have alkalosis?
It's a second line, what are the interpretation? Hypokalemia we agreed.
Yes. Does she improve with?
Is there some clinical information you have?
Does she improve after the treatment with KCL?
Blood pressure. Who said blood pressure? Blood pressure.
Okay. So.
Joint pain, dryness of fine.
Why do you want joint pain and dryness?
Jordan's 21 years old.
What will Jordans have alkalosis? What?
BP is 100.
100 systolic.
They want to come from the down.
Anybody want to know?
Hypokalemia?
Anybody interested in magnesium?
Urine potassium, TTKG. Family is urine potassium, TTKG. Typically, it would come to Bartle's detriment. Family is
We will be very often in this case in this area.
It's a,
Yeah, maybe 1 or 2 episodes of vomiting. But most of it was like body paralysis.
so basically case of hypokalemia with metabolic alkalosis. So differentials for that we should find out. So it's hypertensive or not hypertensive. The hypertension is dependent on the
Not hypertensive.
not hypertensive. So it's not renin dependent. That is the reason. Here it looks like more of metabolic surge, and there is past history is also there recurrence.
So what metabolic?
Hypokalemia.
Yeah, hypokalemia. What's the cause? You said it could be hypertension, normotensive. Now you said no hypertension, normotensive. So this is a normotensive person who's got periodic paralysis. So what's the cause?
What is the cause for his hypokalemia?
Yeah, what's the cause for hypokalemia?
This is sodium level in the university. That's
Which syndrome you want to put?
so Barter and Gentleman.
What investigation further do you want? Any calcium, excision, magnesium?
Calcium, urinary calcium and magnesium.
Calcium?
Magnesium also.
Let's see. You don't have those. Okay.
Urinary potassium, I think, was 22. Urinary potassium creatinine ratio was 23.
So what did that suggest?
So it's a renal cause.
So it's a renal cause. So what renal causes cause?
So maybe there is any diuretic use of the
Diuretic?
No
She said
diuretic.
no diuretic use. So anything else that you would want to know? If I tell you that she has had recently some fever and urinary tract infection and some so would you want to know anything else?
Also.
Can the aminoglycosides do this, long-term aminoglycosides?
What is an acquired cause? You are putting only diuretics. Other than diuretics, anything else you have to think?
It's a tubular dysfunction. Potassium more excretion of
It's a renal, no.
So acquired and genetic causes. So acquired, we try to rule out, you said diuretics, aminoglycosides, anything else?
Amphotericin?
Yes.
Very strong drug for causing hypokalemia. Very, very strong.
How will you treat her? Suppose you made a diagnosis. How will you manage this patient? She is having recurrent episodes, no? Hypokalemia also.
Yes.
So, what can we do to prevent this from happening again?
I will first evaluate the cause for is it organic or not? Here it is non-organic. So then hypertensive, non-hypertensive, and then again the cause for potassium I want to find out.
Yeah, no. So how will you treat?
So IV potassium chloride.
No, that's okay. But after she goes, she has multiple episodes, no? Recurrent episodes of hypokalemia. How can we prevent a episode?
Another episode of hypokalemic paralysis.
To remove the precipitating factor, any there, any drug.
Usually, if it is, most unlikely drugs are anything because as per past history, it's multiple episodes she has come, right? In the first episode, all occurred, whatever the cause, like drugs, you do not expect them to take every time.
What are the common precipitating events in somebody who is prone for hypokalemia to develop hypokalemic paralysis? What are the precipitating events? Drugs means which drug?
You eat something and you can get it.
Patient went for a wedding and came back and then he developed. What did he have at the wedding? Or sweets like kheer or paisam or whatever.
Okay, so treat with the soda backups.
Patient had breathlessness, patient went to hospital, patient was given some treatment for asthma and then developed this. What was he given? These are the precipitating events. Okay, so that aside, how will you treat long term?
Soda backup tablets.
So that alkalosis can worsen?
Sorry, it's alkalosis. Precipitating. Yes, it's wrong.
Amyloride is something which is supposed to have high sodium content in the diet. With amyloride, which is not available as a standalone drug, I think is no longer available.
It's not available now. Even as a combination, it's also not available. Have available combination? I don't know.
Earlier it was available.
Yeah, it used to be available earlier, but now it's available.
It was
Next one, I think.
Good evening, sirs. I'm Naveen Jha from Jupiter Hospital, Mumbai.
This is a 60-year-old male. Actually, currently in the ward. No diabetic, CAD with severe elbow dysfunction. CKD stage 3 with baseline GFR of 35. He presented with shortness of breath, swelling, basic anosarca and decreased urine output, and no chest pain. He had a history of anterolateral wall MI for which PDCA was done, and he has been admitted thrice in the past 6 months with cardiac failure. CKD with cardiac failure.
Anything else you want to know? CAD, pelvic dysfunction. creatinine clearance of 35, swelling, decreased urine output, chest pain, past history of PTC.
So the patient is like diabetic with recurrent episodes of heart failure with reduced ejection fraction. So one organ, end organ damage is there. So other organs like microscopic, urine routine microscopy not required now. Right now, later on investigation, point first investigation.
So at this point that you are called to see this patient in the emergency. So what will you do?
Yeah. So patient has acute kidney injury currently. Patient has decreased urine output since 3 days.
So he has not taken fluid for prostate 6 hours.
And decreased urine output for 3 days. We have
He is already a chronic kidney disease with the GFR of so
acute on CKD, sir. Acute on CKD.
You don't know that, but urine output may be low because his ejection fraction is not down. So he is in heart failure, and so obviously the urine output is low. So what will you do immediately? First thing that you will do.
Yeah. So first rule out cardiac. What is the cardiac scenario? What is the ECG changes acutely? What is it examination? Yeah.
What do you want to examine first?
Yeah. So whether patient has clinical edema fit is there.
See the blood pressure?
Yeah. BP blood pressure.
The blood pressure matters?
Yeah. Hypotension.
96/60.
So mean arterial pressure, BP is 90/60, means it's like borderline on the lower side, not on the higher side. With heart rate, tachycardia.
Why the blood pressure will go down?
Because the reduced ejection fraction is there.
Maybe a
Patient of.
So you have to see the medication what was added.
So saturation is 80. What do you think? Why
Because of pulmonary edema, patient has pulmonary, because of which saturation is on the lower side currently.
So he has got hypotension and
Pulmonary edema.
He is a non-coronary artery disease and CKD.
So he has pulmonary edema because of fluid overload underlying. So because of chest examination, saturation is 80%.
Why is his blood pressure 96 if it is due to fluid overload?
Because of underlying, because of BP, because of maybe antihypertensive medication he might have taken prior to the. Maybe.
On the other hand, he is a diabetic.
Diabetic.
He cannot get chest pain.
Chest pain. Underlying acute coronary event might be a precipitating factor of causing this decreased blood pressure. So to rule out that acute ischemic event.
But this is not an uncommon scenario that you see very in the emergencies. In any large hospital, you will see this kind of patients. These days, you will have patients with heart failure, kidney disease coming frequently, and you are also being called because there is one or the other metabolic or other disturbance.
So you will have to see the volume and the pulse rate, whether this rhythm is abnormal, which is precipitating
acute
and causing his. Yeah, and electrolyte disturbances may predispose to anything for that.
So what are the two drugs which can be used in patients with heart failure, which have tremendously improved the outcomes of heart failure?
So valsartan with sacubitril combination.
So that's one.
It's one drug like sacubitril valsartan. Other is this newer endothelin antagonist work who are 2.5.
Before that.
So ACE inhibitor ARBs are there.
Diuretic is already there.
Yeah.
Third.
So SGLT2 inhibitors. So SGG. Non-steroidal anti.
So SGLT2. So one could be ARNI. Previously were ACE and ARBs, now ARNI, SGLT2 inhibitors, and one of the diuretics is already there. It's not a pillar actually, but finerenone may become a pillar. We don't know yet as such whether aldosterone antagonists like finerenone or others may become. They are already being used but in a patient with 35 ml of GFR, so what would be your, if you were to be called, and what would you will give ARNI or not give ARNI, give SGLT2 or not give SGLT2?
Yes, ARNI and SGLT2 both can be given currently, because potassium level in ARNI we have to mainly monitor currently.
Would you give ARNI to somebody with a GFR of 35?
Yes. We can in this patient, in this blood pressure, it will be bit. We have to monitor the mean arterial pressure and the blood pressure. But to start with, initially we can.
SGLT2 is going to help the patient in the
long term.
At this point, in 96/60, he's been quite rightly put on inotropes, non-invasive and diuretic. 6 hours later, you are called back again to see that all of this has been done, but his creatinine is 2.8 and he has produced only in 6 hours 150 ml of urine.
The urine output is 150, but I will see whether this patient is on.
Now on dobutamine at 2.5 mics per kg per minute. His blood pressure is 110/60. His saturation has come up to 96 on non-invasive ventilation, but urine output is only 100 to 150 in 6 hours.
Urine output is urine output is not the
criteria. Call you.
Yeah.
They have done everything else. They have done the non-invasive. They have done the inotrope. They have done.
Diuretic is already on. Then what you will do?
Now they want to know what would you.
The diuretic infusion, diuretic increase the bolus doses with the threshold dose of diuretics we can increase. See for other at least 500 mg per day, means like 1 mg per kg per hour we can give 1 mg per kg per hour dose of IV furosemide. 1 mg per kg.
60 milligram per hour?
60.
40 milligram, 40 mg per hour.
You could give first dose as a loading
bolus dose.
You could give as a 60 milligram or so. Previously we used to use very large doses at one point, but they have not been. So maybe a 60 milligram as a loading dose, and then you would give probably maybe 25, 10, 20 milligram depending on his kidney function is 35 ml GFR. So you would use something like 10 or 20 milligrams per hour infusion. And maybe in next 6 to 12 hours, if he doesn't produce urine still, then you might have to think of
sequential blockade, adding other anti.
No, I'm sure you will have to think of ultrafiltration.
Yeah, that was the idea. That if diuretics don't work,
then
you will have to think of ultrafiltration.
Ultrafiltration is better, you have to only continue diuretic.
The recent trials, evidences of continued diuretic has been similar in terms of with compared to ultrafiltration.
That's the first. But if diuretics fail,
then ultrafiltration.
Obviously, the choice is to use ultrafiltration. You have to unload. The only way you can unload is by
Too much exposure to diuretics. So now I'm giving you choice: scuff versus PD. What do you want?
Heart.
It's a cardiac patient.
PD will be better. RCT. The comparatively is not there.
There is no RCT, but this is the clinical scenario.
So blood pressure is.
You can't say I'm not going to treat this patient because there isn't an RCT.
Probably PD because.
Probably.
In the actual phase, a patient on non-invasive.
Scuff will be better.
Don't put fluid into his abdomen. So you will need scuff, and maybe later when he's setting up, you can insert a take off and send it.
Chronically, only night I could extend never.
It does work.
Okay. It does work. Or need to 3%. It may work. But acutely better to have a scuff.
I didn't know all this, but
yeah. So that's exactly what happened. We were called back after 4 hours and said that his creatinine was actually 6.8 and urine output was
only
actually
380.
and he was quite breathless on NIV.
So therefore you did an ultrafiltration.
So what
would
would
we
you?
did? We put him on scuff and then we put him on PD now and he's on one next stage of hypertension.
That's what they do very well.
Yeah. So this is what happens.
Okay. So this is what was discussed also. This is what. Yeah, but this is something you need to be aware about because this is a kind of consultation which is very, very common.
Patients of such patients are increasing.
And then the intensivists get annoyed if you don't contribute anything. They say, what have you come for then?
They've called you because there's no output. And you're saying, wait.
Thank you, sir.
Histopathology.
Yeah, Adita. It's okay, we'll do this. These are spotters.
What is he supposed to tell us?
It's Vaiva bar spotters.
Lecture is already had. Answer is out.
Sir, this is the Baxter CRRT machine.
What's the name?
Prismaflex.
Okay. What all therapies can you do with this?
In Prismaflex, we can do scuff can be done, CVVH, DCVH, DF can be done, and plasmapheresis can be done.
Plasma exchange can be done. There are 4 scales on this machine. What are they? You can see 4 bags hanging there.
Yes, sir.
How many pumps are there?
4 pumps are there. 5 or no.
5. So which are those scales and which are the pumps? You've seen this before.
The exposure is limited.
How
Sir.
many have used this machine? You have. So what are the scales and what are the pumps?
Replacement. Replacement.
Which ones? Which one is which?
The colors, color coded.
Yeah, I can see the color. So you
The
can come close and see.
leftmost is effluent.
How do you know that's the effluent?
Yellow.
It's yellow color. Then
Purple is replacement fluid.
which one is that?
Third one.
No, the last one. Far right. Far right one is purple. That is the replacement.
Second is dialysate. Third is PVP.
No, it's the opposite. The white one, the second one, the white triangle, that is PVP. And the green one, the green square is the dialysate. What is PVP?
Pre-blood. Pre-blood.
Usually this for anticoagulation.
So what is specific about why that one? It's also a replacement fluid. Why it's called PBP?
Right after the axis comes out, that time it joins the.
There is a Y connection at the exact point where the blood leaves the patient's catheter. So it delivers citrate right at the point that the blood exits the catheter. So it's meant for citrate anticoagulation. And what do you do with citrate anticoagulation? Which fluids do you use?
Bifurcal.
What is bifurcal?
Bifurcal is the fluid used for dialysate and replacement in a citrate steroid.
Correct. So what's different about bifurcal from routine fluid?
No calcium will be there in there.
And
lower bicarbonate.
How much? Bicarbonate is 22. 22 bicarbonate. Why?
Because citrate will go to the liver and get converted to bicarbonate.
So where is the citrate?
Citrate will be in the PVP.
On the PVP. How much?
3 millimole per kilogram.
3 millimole per kilogram. The manufacturer knows the weight of the patient.
We have to set the.
Do you?
No. You want set now.
has used the machine?
They said they have both used the machine.
It's 18 millimoles per liter. And when you choose regional citrate anticoagulation, there are two options. Regional citrate anticoagulation with Prismaflex pump, regional citrate anticoagulation with external pump. When you choose with Prismaflex, there is in both of them, there is a default setting which comes. What is that default setting? That the PBP rate is automatically about 10 times the blood flow rate. So if you keep a blood flow rate of 100, say 50, then the PBP rate will be 1000 if it's 100. If you keep 50, it will be 500. And at that rate, the citrate being delivered, because 1000, so it is 3 millimoles per liter. So your blood flow is 100 into 60, that is 6 liters, and the PBP is 1 liter, that's 1/6, and since it's 18 millimoles per liter, that comes out to be 3 millimoles. That is the calculation for it. But you can go into the anticoagulation menu and change the amount of anticoagulant you want to deliver. So when it uses that, what you said you're using calcium-free dialysate and replacement fluid. So what happens? What's going to happen to the patient? He's going to get hypocalcemia. How do you prevent that?
We either start external calcium.
There's a pump there for calcium.
Where?
On the side.
4 pumps are there. 5 pumps. Which one are they?
We start calcium infusion external.
At what rate? But you have to, yeah, that's correct. But you've got to start something to begin with. Boluses, no. So if your software is 8.2 version or higher, then you can choose to deliver the calcium with the syringe pump. The pump which normally delivers heparin, you fill calcium gluconate in that. So if it's a software version of the machine is 8.2 or more, then you can choose the calcium neutralization. So it says that you have set whatever the PBP rate to deliver 2 millimoles of citrate per hour or 3 millimoles per hour or whatever, and then you want 100% neutralization, 80% neutralization, 90% neutralization, 110%, you can decide, and accordingly the machine will calculate the rate. Your machine has to have been told whether you are using calcium chloride or calcium gluconate. You have to configure it for one of the two. And then when it says neutralization, the syringe pump rate gets automatically set. And then of course, as somebody said, you will have to monitor. What do you monitor?
Ionic calcium, ionized calcium, post pump citrate also.
Citrate? My lab doesn't do
Post
citrate. How many
ABG
ionic calciums? The ISN guidelines have all this. How many calciums do you do every time? This thing is called what type of anticoagulation?
Regional citrate anticoagulation.
Regional citrate. So if it has to be regional, then you are dissociating your circuit from the patient. The patient's calcium should be normal, and the circuit calcium should be low. So the circuit calcium is targeted to between 0.35 to 0.49, and you draw that sample from where?
Post filter.
Means where? The blue port. The blue port. So you draw that as circuit calcium, and you can draw from, if the patient has an arterial line, an arterial blood gas or a venous sample from somewhere, and that is the patient calcium. So what are the targets? What's the target for the patient calcium? 1 to 1.2. So if your patient calcium is 0.8 4 hours after you started, what adjustment do you make?
Decrease the citrate.
Decrease what? Citrate. So your circuit will clot. Increase the blood flow rate. Increase the blood flow rate. Again your circuit will clot. Or if you have chosen the system, in that, as soon as you increase the blood flow rate, the PBP rate will automatically increase.
Calcium.
You have to increase your calcium. And if, for instance, your circuit calcium is 0.5, then what do you do? 0.55. So you have to increase your citrate. So if if your circuit calcium level is too high, you increase your citrate. If it's too low, you decrease your citrate. If your patient calcium is too low, you increase your calcium. And if it's too high, you decrease your calcium. So the patient's thing is determined by the neutralizing calcium. The circuit is ionic calcium is determined by the citrate.
If the patient has a liver dysfunction,
citrate will not be metabolized.
mild disease you can use it.
Mild disease
you can use it.
Because what will be the manifestation if the patient has liver disease? You take a patient on, this patient happens to have liver disease, is severely acidotic, you start regional citrate anticoagulation, his lactate is around 5 and he is hypotensive on inotropes, you are not able to do ultrafiltration, you have just connected him to try and correct metabolic to begin with, and later we will do you. What will happen?
Acidosis will worsen.
Which acidosis? You will get a high anion gap acidosis with a maintained lactate. The lactate doesn't increase. The citrate is going to
accumulate.
By the liver.
So only thing is you'll have to stop things and you can use heparin if possible or without
anticoagulation.
If you're going without anticoagulation, what should you ensure?
We need to flush the circuit frequently.
Very difficult to flush this circuit. It's a complete closed circuit.
Blood flow should be
Maximum replacement fluid in the pre-dilution rather than.
Unfortunately, that prescription is come too small, but that prescription tells you 2 or 3 things at the bottom. TMP. No, TMP is on this side. But in that prescription, it tells you a few things.
blood flow.
Yeah. It tells you the blood flow rate, PPP rate. It tells you at the end, it tells you effluent rate, ultrafiltration rate, and something else.
Where you have to use your supplements, pre or post?
Pre.
And it tells you the filtration fraction.
If the filtration fraction is high, clotting will be high.
You keep your filtration fraction as low as possible, and you keep some proportion or most of that replacement fluid pre-pump. What is filtration fraction? UFR divided by blood flow rate? Plasma flow rate. So how do you know the plasma flow rate? How does the machine know the plasma flow rate? Blood flow into 1 minus hematocrit. So when you start the machine, it asks you the patient identity, it asks you the patient's weight, and it asks you the hematocrit. And it calculates that. And when you are doing CVVHDF, which all are in the numerator? So denominator is blood flow rate into 1 minus hematocrit. What's in the numerator? Dialysate is what is not. Both the replacement fluids, PBP replacement and patient fluid removal. These are the 3 things in the numerator. The dialysate is not in that. So the effluent rate is equal to PBP plus replacement plus dialysate plus patient fluid removal. And all these but not the dialysate rate is ultrafiltration rate. And all this is shown on the screen.
That all or is there another one for him or which one?
Achha. Oh, I didn't realize. I wouldn't have asked him.
Next person can take.
Two per person. So what investigation is this?
It's a mixture-eating cystourethrogram, sir.
Why do you say so?
Because urethra is also visualized.
What are the things which are visualized?
What
are
can
the
you
things
see?
which are seen?
What all you can see? Can you identify the
Yes, sir. Bladder is
structures?
Bladder is there, okay.
bladder is seen, urethra is seen, ureters. The ureter, one of the right-sided ureter is seen, which is dilated a bit tortuous up to the pelvic alveolar system. So this is an MCU film, sir.
How do you do an MCU?
First, Foley's catheter has to be inserted, and after that, the bladder volume is calculated.
Foley's catheter sense.
And
First to take a scout film.
Oh.
Okay. Which is
Okay.
on the kidney, bladder, and the pelvis.
And the pelvis.
Everything. So it has to be seen. And then you calculate the volume.
Bladder volume and
You fill the
the
bladder. At what rate you fill the bladder, with what you fill it.
not sure, sir.
Ureographene can be diluted in water, or people they synthesize iodine.
Iodine contrast.
So you fill the bladder, how much rate, what rate you fill the bladder?
Not sure, sir.
Take a 50 ml syringe, you will have to with the gravity. You can't force it. If you force it, the bladder contracts. So you will not be able to estimate the capacity also. So by the gravity it should go. Or very slowly you need to push it. So on the first sensation, then you can remove and ask him to void.
Void.
At the cystogram, you need to take a picture. Why you need to take a picture?
To know the contour of the bladder,
1 second.
bladder capacity.
Diverticular passage.
Oh, yes, sir.
You know your field, did you
Okay,
know
okay,
how much
okay.
it is? Then, is it a diverticulum?
Diverticulum, yes, sir.
Then, even a
Trabecular.
cystogram also you can see.
Trabeculations.
Is a low pressure reflux, you can see even in the cystogram.
Cystogram.
Then ask the
Then the patient is void, and during voiding,
During voiding,
this is a voiding film.
right. How do you take the picture when a person is voiding? You take from anteriorly or you take it from laterally?
Not sure.
Take anteriorly, you sometimes you will not be able to see the initial urethra. So you have to take
Oblique. Okay.
So
and
what
the
the-
post void.
So what does it show?
There is a right-sided reflux, probably grade 4, grade 5.
Anything else?
Mm,
Can you notice something about the bladder on the right side?
Is there
Compared
a
to
dent?
the left side?
The left side is relatively smooth and there is an indentation like
Why is that?
Which side is abnormal? The smooth side or this side? So, got the confusion.
not sure. Sir.
So smooth is normal.
No.
Once you put some doubt,
I think there's a diverticulum.
yeah, since you,
Just below.
The-
Yes.
the way you diverticular should now, you need not imagine like it should be like an
Outpouching.
Because
your view is just
it may be posterior, so you only see in the so if you take a other way, then you will be able to
it's
see.
a 2D image.
Okay, got it, sir.
Okay.
Thank you, sir.
Please read both because finally you will get same images and same machine, both DNB and DM exam, and if you do well in that, no, you will compensate for your cases. Examiners will be very happy. If you tell basics of dialysis machine, and if you impressed with how do you do like MC sir.
Go and see
If
when
it tells
the
nicely,
PGs
then
here.
they will be very happy that he has read it. It's the importance of it, how to fill it with just gravity. These are all the minute things if you tell, especially senior examiners who were very fond of your clinical thing, they will be very happy. I mean, you can come till like in the exam till the end, you try to impress the examiner. That's what I can say. If your goal is to
Get through.
Break for tea in the third floor. After tea, we'll gather in the main
Main
auditorium
hall,
and continue the rest.
Okay.
Don't see him.